Start.
Okay.
Hello.
Hello.
Yeah, okay.
Good evening, everyone. On behalf of the organizing committee, I would like to welcome each and every one of you to the second Stroke and Neurocritical Care Symposium. Thank you for joining us for today's webinar from all over the country. My name is Dr. Divya Gopal. I'm an associate consultant in internal medicine. I'm the organizing secretary in this webinar, and I'll be taking you across the entire
Good evening,
program.
everyone.
We are privileged
On behalf
to
of the
have
organizing
a panel
committee,
of,
I would like to
comprising
welcome
of
each
esteemed
and every good evening, everyone, to the second Stroke and Neuro. On behalf of the organizing committee, I would like to welcome each and every today's webinar for the second Stroke and Neurocritical Care Symposium. Divya Gopal, thank you for joining us for today's webinar from all over the country.
This being a digital
My name is Dr. Divya
webinar,
Gopal. I'm an associate
request all of
consultant
you to hold back
across
questions
the entire
till the end of each
everyone.
session.
And the
We are
organizing
on behalf of the webinar, and
I would like to welcome good
evening.
evening, everyone. The second Stroke and on behalf of the organizing committee, I would like to welcome each and every one webinar to the second Stroke and Neurocritical Care Symposium. Thank you for joining us for today's webinar from all over the country. My name is Dr. Divya Gopal. I'm an associate consultant for today's webinar from all over the country. And the organizing secretary of today's webinar, and I'll be taking you across the entire good evening, everyone.
So I just introduced both of you.
I would like to welcome
Dr. Kapil Silve is the head
second
of
Stroke and
Neurocritical Care at UP Hall
I would like to welcome
Grand Medical
today's
Foundation.
webinar from
He's the
second
president
Stroke
of
and
Neurocritical Care Society of India, past president Indian Society of Critical Care Medicine, Mumbai from 2017 to 2018. He's a council member of World Federation of Societies and India Critical Care Medicine. He's the president of Association of SARC Critical Care Society.
for giving me this opportunity. So I'll be talking about intracerebral hemorrhage bundle of care and management of anticoagulation associated intracerebral hemorrhage today. So as we all know, intracerebral hemorrhage comprises about 10 to 15% of all strokes, and it has a very high mortality, 30-day mortality rate, which is around 40%, with half of the mortality occurring in the first 2 days of onset of the intracerebral hemorrhage. The remaining patients, out of them, only 20% of them actually become functionally independent when we see them at a long run. So despite comprising only 10 to 15% of all strokes, it has a disproportionately high morbidity and mortality. Coming to the causes of intracerebral hemorrhage, so the most common cause is the underlying chronic hypertension. We see it comprises about 60% of all cases. Other causes include bleeds which are associated with antithrombotic drugs, underlying cerebral amyloid angiopathy, vascular anomalies, sympathomimetic drugs, and tumors. So why there is a need for an early aggressive treatment of these patients is because more than 20% of the patients are going to deteriorate even before they are reaching our emergency after the onset of symptoms, and another 15 to 23% of them will deteriorate in the first few hours while we are trying to manage them in the emergency, which is a huge number, coming to about 30 to 40% of them are going to deteriorate in the early few hours of the management of the intracerebral hemorrhage. The pathophysiology of ICH basically is because of the perforation of the deep penetrating arteries secondary to the lipohyalinosis, which is seen in patients of hypertension, leading to the hematoma formation. And then the underlying high blood pressures, coagulation abnormalities will further lead to expansion of this hematoma, which will lead to direct brain injury because of the mass effect, can also actually increase the intracranial pressure, cause midline shifts. And because of the hematoma per se, there will be injury to the perihematomal tissue. Later on, there will be formation of the perihematomal edema. There will also be activation of the inflammatory cells, which is leading to the cellular and the humoral immunity activation, which is secondary to blood degradation products like thrombin, iron, and hemoglobin. And all this will further go on to cause secondary brain injury, causing cell death and apoptosis. So what do we need to target in this entire pathophysiology of ICH is the hematoma expansion, which is going to occur early on in these patients, so that we can prevent the direct brain injury, which is occurring because of the underlying ICH, and also the ongoing secondary brain injury, which is going to occur in these patients. So the primary brain injury, as you can see, can lead to raised intracranial pressures, brain herniation, cerebral ischemia, and the secondary injury, which is actually occurring because of the underlying neuroinflammation, which is taking place around the hematoma, the perihematomal edema, leading to cell apoptosis and death. So the hematoma expansion, as we see, it usually occurs in the first 3 hours. There was a study which was published in Lancet of about 5,076 patients, where they said that the highest probability of hematoma expansion will be in the first 3 hours. So about 28 to 38% of the patients who are undergoing CT within the first 3 hours of ICH onset will actually go on to show an hematoma expansion when the CT is repeated 24 hours later. Also, the baseline hematoma volumes of more than 60 ml are actually associated with very high mortality of 91% at 30 days. And for every 1 ml increase in the hematoma size, the mortality is going to increase by 5%. So as we can see that if we act early, we can actually reduce this hematoma expansion and actually try to convert it into some clinical benefit for these patients. The other predictors which say that the hematoma is going to go on to further expand as the use of anticoagulation therapy at the onset and the CT angiography spot sign. So coming to the concept of hematoma expansion, as we see here, small volume hematomas, when they actually increase in size, will not cause a clinically meaningful difference in the condition of the patient. So as for the large volume hematomas, which are usually more than 60 ml, it is the medium volume hematomas which are, when undergo expansion, will actually produce a clinically meaningful difference. And this is the group of patients that we need to target when we are managing these patients. So principles of intracerebral hemorrhage management. So these patients, because of the raised mass effect, can actually have an underlying airway collapse, can have impaired hemodynamics. So the first thing is that we want to stabilize these things. We want to establish the diagnosis of intracerebral hemorrhage by a rapid imaging, do a concise clinical assessment of these patients, documenting the Glasgow Coma Scale, the NIHS's code for these patients, and then go on for early targeted interventions, which include urgent blood pressure management, rapid reversal of the underlying coagulopathy, timely neurosurgical intervention, and appropriate transfer of the patient to the ICU or the stroke care unit. We need to identify patients who are going to have an early deterioration, clinical deterioration, and also we need to identify patients who are going to require intracranial pressure monitoring. And we also need to control the underlying metabolic factors in these patients. So coming to the first part, which is the stabilization of the patients. Once we've done that, we go in for the neuroimaging, which is the CT scan of the brain. Gradient echo and the SWI MRI images can also be used to identify intracerebral hemorrhage in these patients. The various parameters that we can look at while we are doing the imaging is the location of the bleed, what is the volume of the bleed, whether the borders are irregular, there are any hypodensities which are present in the bleed, any air fluid level which is present in the bleed, which will give us an idea whether it's a secondary cause to the intracerebral hemorrhage, and also features of raised ICP in the form of perilesional edema, IV extension, midline shift, brainstem compression, and hydrocephalus. We calculate the ICH volume using the formula, which is the ABC by 2 formula. So here we select the CT slice, which has the largest size of ICH, and A being the longest axis, B being the longest axis, which is perpendicular to A, and C being the number of slices in which we can see the hematoma multiplied by the slice thickness, and this will give us the ICH volume. Nowadays, the CT scanners can actually have an inbuilt system whereby we can get the hematoma volume from that. Then the neuroimaging can be helpful in telling us whether the hematoma is going to further expand with the help of the CT angiography spot sign. So as you can see in the figure B, we can see a small hyperdense area in the hematoma itself. And when the CT of this patient was further repeated at 24 hours, we saw that the hematoma had actually expanded in this patient. So this can be a helpful sign which can tell us whether these patients are at a risk of hematoma expansion or not. So after securing the airway, getting the CT in place, we do a quick clinical exam of these patients. We want to know the time of onset of the symptoms. We want to know if the patient has been on any anticoagulant measures. We monitor the patients frequently with the GCS score and the NIHSS score, and the routine blood investigations plus the coagulation tests are what we will go for and order in these patients. ICH score is basically a score which comprises of 5 components. A total score of 0 to 6 can be obtained, and it is a very good predictor of a 30-day mortality in these patients. As you can see in the graph here, patients with a score of almost 5 to 6 will have a very high mortality of near to 90 to 100%. So this score comprises of 5 components, which is the Glasgow Coma score, the ICH volume, the presence of intraventricular hemorrhage, infratentorial ICH presence, and the age of the patient. Coming to the blood pressure management in these patients, so what do we do? How do we manage the blood pressure in these patients? Do we keep it high? Do we go low? So there are various contentions which are related to the high blood pressure in these patients, saying that the patients who have a high blood pressure will actually go on to have an hematoma expansion. They're going to have rebleeding. They will have more perihematomal edema, and obviously it will increase the mortality and morbidity of the patients. Whereas they say that if we decrease the blood pressures to a very low level, there are risk of reducing the cerebral perfusion pressure in the surrounding tissues. There can be adverse effects in the form of pre-renal compromise in these patients. So how do we manage the blood pressure in patients of intracerebral hemorrhage? To answer this, there were 2 major trials which came into place, which were the Interact-2 trial and the Attach-2 trial. In the Interact-2 trial, they tried to target a systolic blood pressure of less than 140 mmHg within 1 hour of randomization of patients who presented in less than 6 hours of stroke. They found that there was no effect of this treatment on the death or dependency scores, but there was a modest benefit of this treatment on the functional ordinal MRS scores of these patients. Whereas in the Attach-2 trial, they tried to target a LCP of 110 to 139 in these patients who presented within 4.5 hours of the onset of the ICS. They found that there was no effect of this treatment on the death or disability rates. In fact, the renal adverse effects were more in patients where the BP was targeted to be less than 130. So what do we do? One trial says that the BP should be reduced to less than 140. The other trial says that probably it will increase the adverse events in the form of renal compromise in these patients. So to answer this, the AHA came up with their recommendation 2015 saying that patients who have an SBP between 150 to 220 without any contraindications, acute blood pressure lowering to less than 140 mm Hg is safe, and it's actually effective in improving functional outcome in these patients. Whereas the patients who present with an SBP of more than 220 mm Hg, it is reasonable to consider aggressive reduction, but it should be done under frequent BP monitoring and with continuous intravenous infusion. There are two more studies which were published, one in 2019, which was actually a pre-pooled plan analysis of the individual patient data from the Interact 2 and the Attach trials only. And here the authors have actually indicated that achieving an early and stable systolic blood pressure of 120 to 130 mm Hg was associated with favorable outcomes in patients of acute intracerebral hemorrhage of a mild to moderate severity. So actually getting the blood pressure to 120, 130 was safe. And there's another study which is in preprint, which is a secondary analysis of the Attach 2 trial, which says that the patients in this trial who underwent blood pressure reduction within 2 hours of the onset of the symptoms with nicardipine actually had a lower rate of ICH expansion and improved outcomes. So this again reiterates the point that we need to act early and we need to reduce the blood pressure and maintain it at a sustained level so that the clinical outcomes are better in the patient. So this was another paper which was by Parry Jones et al. In 2020, which says that careful lowering of blood pressure needs to be done. Preferably, we avoid reductions of more than 60 mm Hg in the first few hours. Targets as low as 120 by 130 mm Hg are safe, and we need to have a sustained control. That is, there should be minimal variation in the blood pressure for the first 7 days after the onset of the ICH. Then there was another post-hoc analysis of the Attach 2 trial, which was performed, which says that intensive systolic blood pressure lowering can actually reduce the frequency of hematoma expansion even in patients with moderate and severe grade ICH as well, but did not have too much effect on reducing the death or disability in these patients. The various antihypertensive agents which can be used in these patients are labetalol, nicardipine, clonidipine, triglyceryl nitrate. Second-line agents like esmolol, hydralazine, and alloprate can also be used in these patients. Coming to the anticoagulation-associated ICH, so the annual rate of hemorrhage in these patients is actually 7 to 10 times higher than the general population, and the rate of hematoma expansion is even more with the vitamin K antagonist warfarin, which is to a rate of 56% as compared to the direct oral anticoagulation agents, which is 38%, and there were high mortality rate going up to 67%. So we need to manage the underlying anticoagulation in these patients to prevent further hematoma expansion and reducing the mortality in these patients. Certain features which can tell us whether it's an anticoagulation associated bleed as air fluid levels, irregular shape and density of the bleeds on the CT, lobar and cerebellar bleeds, and also the CT angiography spot sign and non-contrast CT hypodensities. The various anticoagulants that we use in clinical practice today comprise of warfarin, heparin, direct thrombin inhibitors, dabigatran, and the factor 10A inhibitors, which is apixaban, rivaroxaban, and endoxan. So when we are managing these patients who have developed an anticoagulation bleed, we need to know their half-lives. We need to know the tests which will actually validate whether the anticoagulation effect of the drug is there in the body or not, and what are the specific reversal agents which are available for these drugs. So you can see the maximum half-life is for warfarin comprising of 40 hours, dabigatran about 15 hours, and for all the factor 10 inhibitors, the half-life is around 12 hours. PT-INR is a very good test to monitor the anticoagulation efficacy of warfarin. For dabigatran, it is the diluted thrombin time, but it is not a commonly available test. So we can use the activated partial thromboplastin time. And for factor 10A inhibitors, it is the anti-factor 10A levels, but this is also not a commonly available test, but PT-INR would be good enough for these patients. So once we identify that the patient is using an oral anticoagulation agent, we want to stop this drug immediately so that we can prevent the further hematoma expansion. We want to know when the patient has taken the last dose of the drug to know whether the drug is actually there in the blood still or not. We want to know the underlying liver and renal functions of these patients to see if impaired liver and renal functions are leading to increased levels of blood in the body. Once we've done that, we want our coagulation test, which is in the form of PT-INR and APTT. And if drug levels can be done in these patients, we also want to look at that. So once we know that the relevant concentration of the drug is present in the body, we want to go in and given the reversal agent, we want a rapid reversal, and we also want to maintain the BP less than 140 systolic in these patients to prevent the further hematoma expansion. So for heparin, we can use protamine sulfate, which is 1 milligram for every 100 units of heparin. If the dose is given last 30 minutes, we want to give 0.5 milligram only. And if the dose was given in more than 2 hours prior to the onset of ICH, we want to give only 2.5 milligrams. For heparin, we can use the APTT levels to monitor the activity. Similarly, for low molecular weight heparin, also we can use protamine sulfate. If the dose has been taken in more than 12 hours prior to the onset of ICH, we only need to do the reversal if the renal functions of these patients are impaired. For warfarin, we need to straight away go ahead with giving 10 milligrams of IV vitamin K slowly over 20 to 30 minutes. Administer 4-factor prothrombin complex concentrate. Depending on the INR values, we can calculate the dose that the patient requires. We check the INR at the end of the infusion. If it is still more than 1.3, 1.4, we want to go in and repeat another set of the prothrombin complex concentrate in these patients. For dabigatran, the specific antidote which is available is the idarosuzumab. It's a costly antidote for dabigatran. It is given in 2 doses of 2.5 grams each. For the factor 10A inhibitors, the specific antidote which is available is andexanet, which is given as a bolus dose followed by a continuous infusion over 2 hours. If these specific antidotes are not available, we are not supposed to wait for them to be available. We can go ahead and give the prothrombin complex concentrate in these patients. If the drug has been taken in less than 2 hours prior to the onset of the ICH, we can also give activated charcoal in these patients, 50 grams, to prevent the absorption of the drug. And hemodialysis can be done in patients who are on dabigatran if urgent removal of the drug is required from the body. For TPA related bleeds, cryoprecipitate is used, and we can repeat cryoprecipitate till the fibrinogen levels are more than 150 milligram per deciliter. Other antifibrinolytics like aminocaproic acid and tranexamic acid can also be used for patients who have TPA related bleeds. So the advantage of using prothrombin complex concentrate over FFPs is that you don't need to thaw PCCs. They give a rapid reversal within 30 to 40 minutes of giving the agent, and lesser volume is required to reverse the anticoagulation in these patients. The various trials looked at the hematostatic agents, and they found that they were actually useful in decreasing the hematoma expansion in these patients. There were 3 trials: FAST trial, Spotlight trial, and the Stop It trial, which used recombinant factor 7A in patients of spontaneous ICH. But all the trials actually had negative results, and they said that they did not improve the radiological findings in patients who had parenchymal ICH. Whether platelet transfusion should be given to patients who are on antiplatelets and develop an intracerebral hemorrhage. In fact, the patch trial actually said that the transfusions are not helpful and actually resulted in adverse events in these patients who had antiplatelet induced bleed. Then coming to the neurosurgical interventions, for the infratentorial bleeds, we want to go for an urgent surgical evacuation if the size of the bleed is more than 3 centimeters in size or the patient is neurologically deteriorating. Also for small bleeds who have brainstem compression features or hydrocephalus, we want to go in for an urgent surgical evacuation. For patients with IV intraventricular hemorrhage or hydrocephalus, placement of an extraventricular drain can be helpful. The CLEAR 3 trial actually compared the 2 groups of patients where who had intraventricular hemorrhage. In one of them, they used alteplase, and in the control group, they used normal saline. They found that it did not improve the functional outcome MRS scores, but the adverse events which were seen with alteplase were actually less as compared to irrigation with normal saline. So this is something which we need to look out for in future trials, whether this can actually be helpful for the management of these patients. For supratentorial bleeds, usually surgical evacuation is done as a life-saving measure only in patients who are deteriorating based on the results of the Stitch 2 trial. But now the minimally invasive surgical techniques are available where they say that evacuation in patients who have a moderate GCS score between 5 to 12 with larger hematoma volumes, surgical evacuation can be performed between 7 to 24 hours after the onset and safely up to 72 hours also. And they actually demonstrated in the minimally invasive surgical techniques that the functional outcome of the patient can be improved if we achieve a surgical goal of a residual ICH volume of less than 15 ml. So this is something that we should look at for and in the future studies and trials. So this was the ABC hyperacute care bundle, which was employed in one of the hospitals at Manchester by Perry Jones et al., where they tried to achieve a target of anticoagulation reversal in less than 90 minutes of arrival, blood pressure lowering to 130, 140 systolic in needle to door time of 60 minutes, and neurosurgical reference in patients who had a GCS score between 9 to 5, ICH volume of more than 30 ml, posterior fossa ICH, and obstructed third and fourth ventricle. And they actually found that there was a 1/3 reduction in the mortality rate of these patients at 30 days, which was a huge number. So summarizing, once we suspect that the patient has ICH, we secure the airway, get a rapid CT imaging, do a brief clinical history, know our GCS scores and the ICH scores, reduce the blood pressure to a targeted level, reverse the hemostasis, refer the patient for surgical intervention if it's a life-threatening deterioration in the patient's condition or a cerebral bleed of more than 3 centimeters in size. Consider EVD if there is a suspected intracranial hypertension or the GCS is less than 9, and appropriately transfer the patient to a specific stroke care unit or the ICU. Secondary complications which are seen in these patients are in the form of perihematomal edema and intrahematomal edema. So we should know that this hematoma, this edema is going to peak at about 4 to 5 days from the onset of the symptoms, and it can remain up to 21 days as well. It can be vasogenic, cytotoxic due to the underlying neuroinflammation as well. Targeted therapies would be that we need to keep the ICP less than 20 mm Hg and cerebral perfusion pressure of about 60 mm Hg, elevation of head end, adequate sedation, osmotherapy in the form of mannitol, hypertonic saline can be used, hypothermia, and in medically refractory cases, even surgical decompression can be done. Is there any role of steroids in the management of intracerebral hemorrhage? So there was one study which looked at use of dexamethasone in 93 patients, where it was used within 48 hours of onset of the illness up to 9 days total, and it was halted because there were very high rate of complications in these patients, and there was no clinical benefit of use of steroids in these patients. The other complications in the form of seizures. So there is no role of prophylactic anti-epileptics in these patients. Use it only if the patient has a clinical seizure. If you feel that the level of consciousness of the patient is way depressed compared to the imaging of this patient, go in for a continuous EEG monitoring, which can actually pick up 35% of electrographic seizures. And if found, we need to treat it with anti-epileptic medications. DVT prophylaxis, we can start DVT prophylaxis after 1 to 4 days from the onset of the ICH in stable hematomas using low molecular weight heparin or unfractionated heparin. Now the concept of neuroinflammation related secondary injury in patients with ICH, as I had pointed out earlier, after the hematoma expansion takes place and the perihematomal edema is formed, there is a lot of neuroinflammation which is taking place around the hematoma in the form of activated microglial cells, macrophages, which are releasing a lot of inflammatory mediators around the hematoma, which are actually leading to the secondary brain injury that we see in these patients. So there are various agents which have been tried in phase 1 and phase 2 trials, which look to be promising in the form of minocycline, celecoxib, fingolimod, deferoxamine, and IL-1 beta. And these are the agents that we should be looking forward to in further clinical trials. And if they receive any approval, we can use it in our clinical practice. So do clinicians overestimate the severity of intracerebral hemorrhage? Yes, as compared to acute ischemic strokes, this study says that they actually overestimated the volume of ICH, they overestimated the volume of severity of ICH, and they also overestimated the prognosis of intracerebral hemorrhage as compared to patients who had acute ischemic stroke, leading to clinical nihilism, leading to lax attitudes in management of these patients, and leading to poor outcomes. So the AHA 2015 came up with guidelines saying that the DNR orders in these patients should actually be taken after 2 days of proper management of these patients only, and not before that. So I would like to finally conclude my presentation with these take-home points, that it's a time-bound management for patients of intracerebral hemorrhage. The hematomas are going to expand in the first 3 hours. So that is when you need to act and act fast. The cerebral edema is going to peak at 3 to 5 days. So that's the time when the patient can go down clinically. Admit these patients, treat them aggressively, get reversal of anticoagulation, get the blood pressures to a target range of 130, 140, and neurosurgical interventions when required. Manage these patients in acute stroke care units, and it will be the intensity of treatment and not giving up too early that will make a difference in the management of these patients. And look forward to future therapy, which is targeting neuroinflammation in these patients. Thank you very much for your kind attention.
Yeah, thank you, Divya, for a very informative and a very lucid talk about the management of the IC bleed. Stay around at the end of the this session. We'll come back with the question answer. So we'll go ahead with the next speaker. Next speaker is Dr. Karthik Ganeshan. He's a head CT MRI and division chief of the body and head neck imaging from the SRHN imaging department. He's MBBS DNB as well as the fellowship in USA. He has 80 peer-reviewed articles and scientific papers, and also he has received the best GI paper award. Plus, he's a visiting professor of radiology, University of the British Columbia, Vancouver, Canada. And he's also director of advanced imaging workshop in training. I request Dr. Karthik to go ahead with the neuroimaging in intracerebral bleed. Thank you. Over to Dr. Karthik.
Yeah. Thank you for the introduction, Dr. Serpe. I hope I'm audible enough. Yes. Good evening, everybody. Thank you, Dr. Arun Shah, for the invitation. And also to the chairpersons, a very good evening, Dr. Nadkarni. I can see you over there. So thank you for having me over. Over the next 20, probably a couple of more minutes, I might just shoot over the time. I'll briefly show you what exactly target raging really plays a role when you're looking at the non-ischemic component of stroke imaging. By and large, what I would kind of divide this is into 5 parts. One is that CT or MR is a great localizer of a pathology. Now, that could be either intracerebral or extracerebral. And what I call by that is a topographical location or identification of a particular pathology. The second thing would be to subclassify or kind of get into the etiology, whether it's non-traumatic, traumatic, that would be the basic one. I'm going to take out the traumatic component because that's rather obvious. But it'd be more important to know whether it's structural or non-structural. And that's where neurosurgeons are very, very active in this, that we really need to know whether there's something underlying which is the cause of the bleed. The younger the patient, more likely it is going to be so. Elderly patients are going to be worried about a myeloid, hypertension, and so on and so forth. As a management planning tool, it's more of an adjunct. It's more based on clinical, but CT and MR do have an adjunct role to determine whether this patient needs to go for surgery or some kind of a palliative line of management. Complications, yes. Imaging has got significant roles in identifying complications, not only by assessing the initial volume of the bleed, but also whether it's causing mass effect, herniation, compression, intraventricular extension, rebleeds, vasospasms, and so on and so forth. And lastly, it has got a role in prognostication also, but more of an adjunct tool. But primarily, again, it's going to support clinical management skills to say whether we are going to have, whether this patient is going to have a good prognosis or relatively a dismal prognosis. So keeping this in mind, it's kind of got a multi-pronged role. I would say grossly, this is what is a standard stroke protocol which comes into any major unit. And our hospital has got a very robust stroke protocol going on. And you would say that about 15% of your strokes which do come in turn out to be hemorrhagic strokes by and large. And again, we do a CT, and the CT kind of divides that grossly into 3 locations, whether it's parenchymal, whether it's subarachnoid, or whether it's subdural, extradural. Now, I would not be looking at the subdural, extradural component. I would be primarily looking at parenchymal and subarachnoid. If indeed it's parenchymal, you would have to again subclassify it into its lobar or its deep central locations, vis-a-vis whether it's atypical, of course. When it's atypical, you know that you got to look for certain oddballs out, like venous infarctions, look for AV malformations, look for an underlying neoplasm, and then your kind of management moves away from a standard CT to either a CTA or an MRA to look for vascular malformations, MRV if there's a venous infarct. But more importantly, if you're looking at tumors, SOLs, you bring into the entire gamut of imaging, like tumor protocol imaging, PET CTs, and then, of course, if required, even biopsies. Grossly speaking, we would divide this into two components, the intra and the extracerebral, and I would be looking at the dominant intracerebral, and from the extracerebral component, purely only subarachnoid. So what I'm going to do over the next about 25 odd slides is kind of giving you all an identifying, what I would say, pattern recognition of certain bleeds and how we are able to use that and detect that using cross-sectional imaging. So if you take this standard, this is a normal brain CT, which is seen out here. The level of the basal ganglia, you can see the frontal horns coming up. You can see both thalami, the gangliocapsular location. So this is a standard normal CT at the level of the basal ganglia. By and large, when you're looking at patterns of bleed, we grossly divide that into lobar bleeds. Lobar bleeds are typically cortical, subcortical, large volume lobar bleeds. Most often, these are in elderly patients, they're associated with a myeloid angiopathy, but of course, hypertensive bleeds, and of course, a large potpourri of pathologies like tumors and so on and so forth can also present with lobar bleeds. The classic bleeds, which are microangiopathies, ischemic microangiopathies, the deep bleeds, the one which affect the gangliocapsular location, the thalami, the deep gray matter, the pons in the cerebellum are the hypertensive bleeds, and these are kind of subclassified as the deep or the central bleeds. The extraparenchymal, but still not purely a subdural and extradural one, is what we have as a subarachnoid. They could be intrasulcal, intrafissural, cisternal, but based on the locations of the subarachnoid bleed, we can also get or presume the likely cause, whether it's aneurysmal, whether it's non-aneurysmal, perimesencephalic, benign bleeds, or you have conditions like RCBS, PRES, and drug-induced bleeds, which can also have a presentation with subarachnoid hemorrhage. So when you're looking at standard patterns of bleed, this is kind of sine qua non of what we see with deep bleeds and which are associated with hypertension. Three classical locations. The one here, which is affecting the deep gray area, that's the thalamus with typical dissection into the third ventricle and the frontal horns. You have a dorsal pontine lesion, get into what you would call the peduncular area and therefore into the roof of the fourth ventricle with an intraventricular extension. And of course, you have the last one, which is the cerebellar bleed, which is sitting right up here. And you can see that there's a small fourth ventricular component. Now, these are standard bleeds, which you say in your day-to-day practice. But what's more important? As a radiologist, you're just not there to say that there's a bleed or not, but you've got to measure certain things. The most important one is the volume of the bleed. The volume is a great predictor, and we also know that the volume of bleeds rapidly increases within the first 3 to 4 hours of an initial onset or of the ictus itself. So it's very critical to remember that when you have bleeds at certain critical sites, you need to be getting these patients back in just to see whether these bleeds are increasing. And usually they do within the first 24 hours. You look at the mass effect, which is generated by the bleed. In initial hyperacute bleeds, you do not see that much amount of vasogenic edema. The vasogenic edema tends to build few hours later, and then it kind of maximizes beyond about 48 to 72 hours later, and then it stabilizes till about a week, 2 weeks. So you've got to remember that sequential follow-up imaging of these bleeds is very paramount because you really need to know what's happening in terms of mass effect. Other important features would be posterior fossa, simply because of the crowding of the space, tonsillar herniations, and so on and so forth. And also, when you're looking at intraventricular extension, you need to be very careful also when you're assessing these scans. So these are the classic sites of hypertensive bleeds, which are seen in these patients. How do you actually come to know when you look at a CT whether this is a classic hypertensive bleed in a patient who doesn't give you that history, or are we looking at something else underlying which is sinister? This is though by location, this is pretty much very sine qua non for a hypertensive bleed. It's got a kind of it's a well-circumscribed lesion. You don't see variegatedness of density of the bleed per se. You can see that the margins are pretty smooth. There's no fluid levels. By and large, you know this is going to be a hypertensive bleed, but you can use ancillary imaging. Those CT is the mainstay of imaging. We occasionally use MR when you want to characterize a bleed or you're really not sure whether there's something underlying over there. And something which is very useful is when you're looking at this continuous rim sign. So whenever you get a continuous rim, either on the T1 or on the susceptibility weighted images, it usually means that that hematoma is a benign hematoma. Once that rim or that rind is irregular, is discontinuous, is broken down, is incomplete, you need to be worried whether there's something kind of underlying which is causing the bleed itself. Secondly, when you see variegatedness in the intensity or the density of the bleed, that's another sign to tell you that there's something underlying lingering and you need to follow up these patients. In many of these patients, what you get to see is the concomitant amount, or whether this is a hypertension, is a great way to just look at the basal ganglionic area. And you have initial signs of a hypertensive microangiopathy. You've got these cerebral microhemorrhages, which are sitting up in the thalami, the gangliocapsular location, and there are old evidences of bleed in the putamen, which is a very, very common site. So this would be a standard hypertensive bleed. When you go beyond this, it's very important to remember that imaging is used on a sequential basis because you want to prognosticate the bleed. You want to see how that bleed is behaving. Most of these deep cerebral hemorrhages, unless they're producing significant amount of mass effect or neurological complaints, are usually followed up sequentially, and you get to see this temporal evolution. Important thing to remember is that when a bleed happens in a hyperacute stage, that's usually within 30 minutes to an hour, it may not be seen in CT as a very, very bright structure. It can appear isoattenuating to the cortex. That's why when you have post-traumatic bleeds and you get these thin subdurals or extradural hemorrhages, they're often missed because hyperacute of bleeds appear isodense to the cortex. You need that clot to actually go up by a couple of minutes to an hour or so for that to start showing formation and retraction, thereby increasing the density. As I also mentioned, developing edema does not stop until a few hours after the ictus, peaks somewhere between about 7 days, 5 to 7 days, and then stabilizes up to 2 weeks. You get to see a large amount of vasovagal edema, a hyperattenuating rind surrounding these bleeds, and they also have significant impact in the outcome of these patients. So this temporal evolution is beautifully seen on CT, and that's what I'm going to show you on this scan out here. In terms of the same patient which I highlighted in the initial images, where you have a thalamic bleed with intraventricular extension, you want to follow this up within 24 hours just to see whether there's increase in size of the hematoma or there's increase in the quantum of perilesional edema. Both of which are not seen in this case. There's no change in the ventricular dimension. There's no overt mass effect. And you follow this patient up over the next about a week and one more week later, and you see this beautiful evolution of the hematoma. The clot has retracted, becomes smaller in size. The density has kind of reduced. And by the time you reach 2 weeks, the standard benign bleed appears isoattenuating to the white matter on the CT scan. This is a classical temporal progression of a bleed. And this is where CT really plays a role when you want to see these benign bleeds. Here's another example of the same. You have a bleed which has happened within half an hour of the ictus, and you can see that that patient has been brought in stat to the scanner. You can see a small bleed in the left thalamocapsular location. Look at the density of this bleed as compared to what you see about a day later. Simply based on the hemo concentration, the clot formation, and the retraction, the density of that clot is significantly more higher than what you see on the initial imaging. And of course, as you tend to follow it up, you can see that though there's hardly any vasogenic edema on day 0, not much seen on day 1, but you can see that by day 7, the vasogenic edema is far more profound as compared to what you see on day 1 itself. And as you go literally towards the fag end of the second week, the edema is still there, but kind of balanced out to what we see on day 7. So to assess a bleed, you're just not only assessing the bleed, but you're also assessing the quantum of perilesional edema, because that adds on to the neuroinsult. That's kind of the penumbra to the umbra of the bleed which you're locating. And therefore, that's very critical because there's always decompensation There's lack of oxygenation in that location, and that you don't want that tissue to actually die, undergo apoptosis over a period of time. So temporal evolution is also a great fact. CT. Other things with hypertensive bleed, you should remember that they don't always present just purely with a parenchymal component. When you have deep gray matter involvement, you have superior or cerebellar or brainstem bleeds, very often than not, especially cerebellar bleeds, Vernian or hemispheric, they're often associated with a subarachnoid component. Now, the subarachnoid component could be purely restricted to the interfoliar areas, or you can see that extension typically into the prepontine cistern and even into the ambient cisterns going towards the retrothalamic area. So this is something you've got to remember, because these bleeds also behave differently and they have a different impact on terms of the outcomes itself. More importantly, when in an acute setting, what exactly we do a CT is not just to say that there is a large volume bleed, there is vasogenic edema, there's mass effect, but the effect of that hematoma around the surrounding parameters, especially when you're looking at the three classic types of herniations, and all these have got profound effect on the overall prognosis of the patient. Classic subfalcine herniation, you can appreciate this on the coronal plane. The same hematoma, you can see how the uncus has kind of gone over the free margin of the tentorium and has squeezed out the cerebral peduncle, effacing out the ambient cistern, completely taking out the perimesencephalic CSF spaces. So this would be a standard uncal herniation. And of course, when you have large volume posterior fossa bleeds, like here in the brainstem intraventricular component along with the cerebellar component, you can see that there's downward migration of the cerebellar tonsils into the foramen magnum. There's crowding at that location, and this is what you would call as a standard acquired tonsillar herniation in a patient with a large volume bleed. Now, all these three syndromes have got significant impact neurologically as well as long-term prognostically. So CT has got a role to play, but of course, it's a purely adjunct tool. You need to use clinical parameters before you decide whether this patient needs to go in for surgical or non-surgical techniques. So once you've got done with the standard hypertensive bleeds, I would like to kind of push towards lobar hemorrhages. Now, this is something which is very important because there are a plethora of conditions that actually cause this. And what I call this as is a peripheral pattern of hemorrhage. Now, most of the time, you've got to see them with elderly patients in their late 60s, 70s, and 80s. You'd see these as peripheral, small or large volume bleeds. More often than not, the majority of conditions where it is amyloid angiopathy. And though we are used to seeing lobar hemorrhages, what are the ancillary features which may allow you to pick the diagnosis of amyloid angiopathy? The one which is most often associated is the microhemorrhages. And the microhemorrhages are what you see here, tiny dots on the SWI image, which are cortical or subcortical in location. You can appreciate all these microbleeds sitting up here. Excuse me. Important to remember is that though they have a peripheral preponderance, they tend to spare the deep gray matter. The thalami, the basal ganglia, and the gangliocapsular regions are not affected in these locations. A very important sign to remember on imaging is that you can get this pial hemosiderosis or superficial siderosis, which is purely peripheral. Now, most subarachnoid bleeds affect the basal cisterns, the sylvian fissures, the perimesencephalic spaces. But when you have subarachnoid bleeds with amyloid angiopathy, it's usually peripheral, it's involving the cortical area, and it's just what we call as convexity SAH and not the standard basal SAH. Additional findings could be dilated perivascular spaces in the subcortical white matter, unlike than what you get with the atat criblé in the area of the basal ganglia, which is typical of hypertensive pathologies. When you get lobar hemorrhages, also what we need to know is it purely amyloid or is there something going along which is structural in nature? Now, here's a classic case of what we call as a arteriovenous malformation, and these are often very common causes of lobar bleeds. They occur typically in young to middle-aged patients, and something to remember is younger the patient, higher the chance that there is a structural lesion which is sitting up here. Now, numerous classifications which are available, but again, they're primarily based on a lot of parameters like the size, the eloquent brain matter which is affected, the patterns of venous drainage, and of course, certain supplemental features. And based on that, you tend to come to a grade scoring of less than 6 or greater than 6. But by and large, these are what we call as AV malformations. You measure the size of the nidus, look for perilesional edema, and look for the patterns of drainage. Superficial, but if you get deep drainage, it is a little more complicated in nature. So here's a classic case which you presented to our ER sometime back, and here you have an atypical bleed in a young patient. This is a lobar bleed in the temporal lobe. Again, one location which you need to always carefully look for is venous sinus thrombosis. But when we do a CTA in this patient, you see an abnormal leash of vessels, which is seen along the anterior-inferior aspect of the hematoma. And if you look at that single large draining vein, it's draining into the left middle cerebral vein. So this would be a relatively small size, less than 3 centimeter nidus, which is draining into the superficial system, which is ruptured, occurring in a patient who's between 20 and 40 years of age group. So this would represent a standard AVM. Now, this is a role where CTA really comes into play, that when you're looking at lobar bleeds at atypical locations, which don't follow into standard vascular territories, they overlap vascular territories. They are in this odd location, which are subcortical, sparing the cortex. You need to start looking for atypical causes of bleeds. And this is one classic example. Cavernomas, great limits. You get to see them very often in the posterior fossa, but you can get these as very large lesions, again, in the supratentorial hemisphere itself. They can mimic neoplasms or even large hematomas, but this classic popcorn appearance, which you get to see along with that continuous hemosiderin rind, is actually a giveaway to the diagnosis of what we call as large cavernomas. These are, again, they form part of those cryptic angiomas, capillary telangiectatic spectrum. There are about 4 subtypes of cavernoma, purely academic, does not have an impact when you're actually looking at clinical medicine. Very important, especially in elderly patients, that when you get to see atypical bleeds, now when you mean by atypical bleeds is location-wise, but also morphologically, you start to see fluid level in a patient who's not an anticoagulant or does not have deranged INR. You get to see a differential attenuation lesion. So here you have a complex solid area with a solid cystic component and a fluid level. When we give the contrast, you see that that's a papillary enhancing nodule. When you look at these kind of bleeds, when you look at these well circumscribed rounded bleeds, you need to worry whether there's something underlying in this patient. Now here is a classic example of something in the posterior fossa with a papillary nodule and a fluid level, which is due to an acute hemorrhage. We did the whole body, especially the chest and abdomen, and we picked up this mass lesion along with large hilar and subcranial nodes. We did a biopsy. This was adenocarcinoma of lung, which is metastasized to the brain and presented as an acute episode with a hemorrhagic metastases. Similar episodes here. You had a patient with bilateral cortical blindness as a presentation, and he came to the ER. And on ER, you can actually see 2 hyperattenuating lesions seen in the occipital lobes, the larger one on the right. But there's surprisingly one more sitting up more extra, you would say, on the surface, on the PL surface. And when we followed up this patient, we did a PET scan and we found up a metabolic active lesion in the lower limbs. It turned out to be a melanoma of the foot, which had actually presented as a primary metastases to the brain itself. So you've got to remember these atypical presentations as well.
Dr. Karthik, I request you to please finish, if possible, in 2-3 minutes. We are already for sure.
Yeah,
it's a request.
Please. Thank you. So here, a little more slides on just coagulopathies, where you can see multiple fluid levels. This would be sine qua non for a coagulopathy-related intracranial hemorrhage. Similar one sitting up here, where you have deranged INRs in patients with hepatic encephalopathy. Cerebral venous infarctions, yes, you've got to remember them as large lobar bleeds, sparing of the cortex, significant amount of vasogenic edema, and you have hyperattenuating clots or hyperdense clot material within the sinuses, something else to remember. SAH, again, pretty much, standard thing when you're looking at basocisternal pathologies. You've got to run a CTA in all these patients so that you don't miss small aneurysms. So here's a classical one which you're seeing from the terminal ICA. And you can see this is the DSA picture of the same and post-coiling. So subarachnoid hemorrhage with secondary to aneurysms. Important to remember carotico-ophthalmic aneurysms in relation to the dural rings. Aneurysms beyond the distal dural rings are going to present with subarachnoid components, whereas aneurysms which are proximal to the distal dural rings more often present not with subarachnoid hemorrhage, but with localized hematomas. Now, that's something which on imaging you can easily pick up. When you see for one aneurysm, you look for multiple. So here there are multiple in the right mainstem and it's bifurcation. And here's an IC aneurysm. Again, important complications which you get to pick up. Vasospasm, typically day 4, day 5 after subarachnoid bleed. And here is a classic example. And there's a ruptured IC aneurysm sitting here with the teeth sign. Benign perimesencephalic hemorrhage, very often you get to see that in your clinical practice. Posterior fossa bleeds running into the cervical canal in this location. Angios are completely normal. We follow this patient a week later with a standard MRA and is pretty much showing no vascular pathology. So this is a very common mimic. I would like to just end up with a couple of slides on RCVS. This is basically a reversible cerebral vasoconstriction. They can present with subarachnoid hemorrhage or lobar bleeds. And here you have multifocal sites of peripheral narrow, what we call the beaded morphology. And then on calcium channel blockers, you can see that vasospasm has been taken care of. So I would like to just say thank you for the invitation for this lecture. I've tried to cover in brief what is the role of neuroimaging in acute stroke. Yeah, thank you so much.
Okay, thank you, Karthik. Our next speaker will be Dr. Rajan Shah. To introduce Dr. Rajan Shah, he is a consultant with the Neurosurgery Department at Sir H.N. Reliance Foundation Hospital and Research Center. He completed his MBBS from Mumbai University in 1979, followed by MCH Neurosurgery in 1986. He has undergone advanced training in neurosurgery at Beaumont Hospital, Dublin, Republic of Ireland, for the period of 3 years. Traveling fellowships at Mount Sinai Hospital, New York, Fujita University Hospital, Japan, and others to obtain experience in management of microscopic surgical management of neurovascular and skull-based diseases. He has an experience of over 3 decades and has managed more than 450 cerebral aneurysms, 100 arteriovenous malformations, and 800 brain tumors with internationally comparable outcomes, and has gained significant experience in looking after acute diseases like brain injuries and strokes. His special interest lies in management of trigeminal neuralgia, offering both the options of microvascular decompression surgery and percutaneous RFTC, radiofrequency ablation of the trigeminal nerve. He's well versed in management of spinal tumors and various other kinds of degenerative spinal pathologies, including the minimal access root procedures. He has presented his work at many and various platforms and authored more than 10 publications. So I request Dr. Rajan Shah to give his talk today on the role of minimally invasive surgery in intracerebral hemorrhage. Dr. Rajan Shah.
Thanks, Srimu, for the nice introduction. Thanks, Dr. Arun Shah and his team for giving this opportunity.
Dr. Rajan, I've just been informed that since we are running a little short of time, at the end of 20 minutes, I'll just give you a kind of...
yeah, that will be great. Yeah.
Okay. Yeah.
I'll finish before that.
Yeah.
Okay, the role of surgery in supratentorial spontaneous intracerebral hemorrhage is quite controversial, and we'll try to decipher the literature and my experience on this, and let's see what conclusions we reach at. As Dr. Priyanka has already said, it is a very morbid type of stroke, forms about 15 to 20% of the strokes in the Western world. Unfortunately, in the ancient countries, it has been reported much higher, to almost 30%, and 30 days mortality is between 30 and 50%, of which 50% succumb in the first 24 hours. The typical locations Dr. Karthik has already mentioned, so I'll not waste time on that. CT images of these typical sites. Now, there are many therapies which have been investigated and recommended for treatment of the spontaneous intracerebral hemorrhage, but most of them have failed to show a significant improvement in the outcome. The cause probably is the secondary injury, even from the residual hematoma after the evacuation of the clot. However, hematoma evacuation and resolution of based neuroprotection seems to be the promising option for the treatment of intracerebral hemorrhages. The current guidelines, I think Dr. Priyanka has already spoken about: early protection of airway, control of malignant hypertension, coagulopathy, blood sugar management, treatment of clinical seizures, they have been already described. But surgical evacuation of in selected patient is something what we will be talking about. The landmark trials, STITCH and STITCH 2, which concluded there was no obvious benefit of surgery for suprarenal intracerebral hemorrhages. However, they have come up with some recommendations. They have also identified a cohort of patients which would benefit with surgery. One of them are lobar hematomas with not so bad glaucoma score. They have also recommended surgery for deteriorating patients, which sort of reduces the mortality in these patients. However, there were a lot of limitations for this trial. There was a large crossover to the surgical group from the medical group, which is almost 21%. There was a selection bias because the patients thought to benefit from surgery were not included, and there was other large number which was excluded due to impaired level of consciousness at the time of randomization. A meta-analysis of randomized controlled trial completed in up to February 2019 by Sondag et al. They have looked at almost 21 studies with almost 4,000 plus cases. They have also shown that there was no significant improvement of the patients with surgery. However, there was a little bias towards the surgery. Their conclusion was that hematoma evacuation holds promise to improve functional outcome and survival at 3 months. And one more thing they have said is that this benefit is in the patients who have undergone minimally invasive techniques and when they were performed early in the disease. Another study, the minimally invasive surgery plus alteplase for intracerebral hemorrhage, again concluded in 2019. They have also showed that there is a failure of this procedure to help the patient with suprarenal hematoma. Thus, pragmatic use of the surgery in intracerebral hemorrhage cannot be recommended. However, they did show that there is a benefit from effective reduction of clot burden. And there is a limitation of this study, especially there's a criticism for this study that the surgery was delayed in these patients. They have also looked at the timing of surgery, the benefit of the timing of surgery. Most of the patients who were operated upon earlier in the disease, they responded much better than their own study because there was an average delay of surgery up to 60 hours from the time of ictus. There is another ongoing study, the Swiss trial of decompressive craniectomy versus the best medical treatment for spontaneous intracerebral hemorrhage. There, they have not evacuated the hematoma. This is the Swiss trial, which is likely to conclude in 2023. The results are awaited. There, the concept is that decompressive craniectomy decreases the intracranial pressure by enabling the brain to expand without damage to the vulnerable brain. This has been extrapolated from the benefit of decompressive surgery in ischemic strokes. So today, the recommended algorithm by these people is that from the ER, if a patient with an intracerebral hemorrhage who has raised intracranial pressure, or there is a cerebellar location, or a CT angio is positive for a vascular pathology in this patient, should go to the neurosurgical theater first before going to the neurocritical care. And the patients who are under observation should have a repeat CT scan between 6 and 24 hours. And if there is an evidence of raised intracranial tension detected on the new scans, they should be subjected to early surgery rather than late. And if there is also a doubt about a hemorrhage from a secondary cause, like a tumor or something of that sort, the patient should have MRI, and the patients who are suspected to have a lesion as a cause of this intracerebral should be also operated early in the disease. There are multiple options, as we talked about, in minimally invasive procedures. One of them is craniotomy and a transcervical interfascicular approach, which is minimally invasive to the brain. Though we may have a large craniotomy, but it is minimally invasive to the brain. Others are stereotactic aspiration, endoscopic assisted aspiration, and the last being the external ventricular drain with instillation of thrombolytic agents. This is, of course, possible only in the patients who have an intraventricular leak of the hematoma which is ruptured inside, and there is some sort of hydrocephalus noted in these patients. With the use of microscope, navigation system, and now the DTI, which sort of shows the shift of the fiber tracks, we can choose a transsulcal approach, which is the shortest to the hematoma without causing any additional damage to already damaged brain from the hematoma. This helps us reduce additional damage to the brain during the surgery and get the best results. I'll show you one of the examples which we had. This is a patient who presented with coma score of 4/15, but fortunately he arrived to the hospital within 2 hours of the ictus. And this was the scan which was seen. The patient was intubated immediately in the A&E and then was subjected to surgery. I'll just show you a surgical clip on this patient. Opening of the dura. This is the sulcus we chose. We are opening the sulcus under the magnification. This opening is not more than about 1.5 centimeters, of which the cortical incision is at the depth of sulcus. So the damage to the brain is very minimal. And we reach the hematoma with less than half a centimeter of corticosectomy during the surgery. And through this small opening, we can evacuate this large clot. And if you see at the end of the surgery, the cortex does fall in together, so there is no additional damage to the brain. This is the preoperative and this is the postoperative scan. This patient had a very good improvement. He went home with normal speech, and of course, there was some hemiparesis, more so in the hand. The other options being stereotactic or endoscopic aspiration and EVD. So in stereotactic aspiration, we introduce a large bore needle or a catheter into the hematoma using stereotactic frame or navigation system, and the hematoma is aspirated using aspiration and irrigation sort of technique, or we use an endoscope to evacuate the hematoma. So in this, we can achieve a significant reduction of the hematoma volume with minimal intraoperative complications. The external ventricular drain based evacuation is based on the Monro-Kelly doctrine, where the skull is a closed cavity with fixed content, which is the cerebral hemispheres, the CSF, and intravascular blood. Right? So when there is an intraparenchymal bleed, there is a raised ventricular pressure, which can be compensated by draining the CSF. The goals of this procedure is to reduce the inflammatory reaction by taking away the intraventricular blood. The CSF drainage of the can reduce the intraventricular pressure, and we can maintain this patency of the EVD by using thrombolytic agents. This avoids the systemic adverse effects from the local installation of thrombolytic agents. Our own experience with the extraventricular drain and intraventricular thrombolysis, we have 23 patients in between 2015 and 2018. All the patients were below the coma score of 8. Some of them were deteriorating patients. And in this, we had to keep the external ventricular drain for about 9 days, but we go on changing the drain almost third day. But what I normally do is put an intraventricular catheter and have a subcutaneous reservoir. So I just put in a needle into that reservoir, which I change about every 48 hours. What we found that almost 30% of the total patients, of which if we consider the patients who have survived, almost 40% or 45% of the patients had a good independent outcome. They were independent in daily living with very little support. These are a few pictures which we have taken on the 5th day of the intraventricular drain. This is the pre-op, post-op. Pre-op and post-op. This is a standard thing. As far as the EVD is functioning, I do not repeat the scan early in the disease. I wait for about 5 days to see the response. Of course, if the EVD is not functioning, then we have to confirm the position of the EVD and probably have to change it if required. About the cerebellar hematomas, as Dr. Priyanka has already said, all the patients with hematoma more than 3 centimeters, ventricular obstruction and hydrocephalus, they benefit with early surgery. The meta-analysis also confirms the same thing. The increased probability of survival at 3 months to 80% from 40% in the surgical cohort of patients. Aneurysm-related ICH, IV, intraventricular hemorrhage or subarachnoid hemorrhage is one of the devastating forms of stroke. Only 30% or 1/3 of these patients come back to their original profession, and it involves a younger age group compared to the other strokes. The life-threatening complications of aneurysms are raised ICT, rebleeding and vasospasm, besides the others which are easily treatable. The preventable complications of these are raised intracranial pressure and rebleeding. The rebleeding chance is maximum in the first 24 hours, which is almost 4%, and then it drops down with time. However, it remains 1 to 2% per day for the next 2 weeks. The options for the treatment of aneurysms to prevent rebleed will be obliteration using either microsurgical clipping or coiling. I'll show an interesting patient. This is again a patient who presented to us grade coma score of 5/15 with an intraventricular hemorrhage. In this patient, we put an intraventricular catheter. Ideally, we should have coiled this patient, but there was a lot of cost constraint. So we waited for a week, and within 1 week, we found that the ventricles had cleared off using the thrombolytic agents. Of course, there was a risk of rebleeding here, but there was no choice. And at this stage, we took the patient up for CT angio, which showed an ACOM aneurysm, which was the cause of this intraventricular bleed. And then we went ahead and operated this patient for the clipping of the aneurysm. So it was a very angry looking brain. As you see from here, we drained some CSF from the cisterns around the optic nerve to in fact, give a little relaxation to the brain. Then we opened up the Silent fissure. This is the Silent fissure we are opening up. This is a frontal lobe, temporal lobe. And this is where we've reached the internal carotid artery, the optic nerve. This is the anterior cerebral artery, the A1 part of it. We traced the A1 to the aneurysm. Both the A1s were identified, both the sides, so we could put a temporary clip before the final clipping to avoid an intra-surgical rupture, which can be quite catastrophic. This is the lamina terminalis, the third ventricle. We did a third ventriculostomy here to sort of drain away some more CSF and get relaxation of the brain. Now, this is the aneurysm which we're just seeing. This is the aneurysm which we're just seeing. These are the temporary clips to sort of get a little relaxation of the aneurysm and avoid intraoperative rupture. These are temporary clips on both the A1 branches. And this is the aneurysm neck, which we have identified and which you're putting a clip on. In fact, here we had to do tandem clipping because only one clip, with that, the aneurysm did not collapse completely. So to make sure that the aneurysm is well secured, a second clip was also put in. Again, this patient made a good recovery. Of course, it took a long time. She was in the hospital for almost 6 weeks, but she went home with minimal deficit in the form of short-term memory problems. Contrary to the ISET study where they have said that coiling is much better than surgery. However, the recent trial of Barrow's ruptured aneurysm trial, the BRAC trial, they said there is no difference in the outcome between the two treatments of anterior circulation aneurysms. So in a patient with raised intracranial tension and an anterior circulation aneurysm, we do recommend surgery to take care of both the pathologies at the same time, Now, the next cause of the intracerebral hemorrhage, which spoke about, is the arteriovenous malformation. This is a patient who again presented with acute onset of altered sensorium, hemiplegia, and aphasia. And this was the CT scan. The MRI showed evidence of an AVM. This is the MR angio, which again showed the AVM. A DSA was done to confirm the arteriovenous malformation. This patient again underwent a surgery for evacuation of the hematoma to reduce ankle pressure and excision of the AVM in the same sitting.
First, Rajan, you finished 20 minutes. If you can just
Okay, so this was the clot removal. And then I'll just show you, this is the AVM, which sort of identified, and we had excised the AVM. Anyway, I think I cut the short this video in the interest of the time. This is the post-operative scan. Again, this patient improved quite rapidly in the hospital, so within 2 weeks. Other thing is tumor-related intracerebral hemorrhage. Again, when there was a doubt, this was the hemorrhage which we were not sure whether this is a venous infarct or a tumor. The MRI showed some evidence of tumor. This was operated upon, and we got good outcome in this patient too. I'll skip the video. Other places, cerebral venous thrombosis with a large intracerebral hemorrhages. This patient also benefits with surgical decompression. This is the post-op, this is the pre-op and the post-op scans. Thank you.
Thank you, Dr. Rajan. We'll come to questions a little later on. So to invite our next speaker, Dr. Vivek Agarwal. He's a consultant brain, spine, and interventional neurosurgeon at the Department of Neurosurgery at Sir H.N. Reliance Foundation Hospital and Research Center. Vivek is a merit list holder in MCH neurosurgery, after which he pursued fellowships in interventional neuroradiology at Zurich University Hospital, Switzerland, minimally invasive neurosurgery fellowship in South Wales in Australia, and a trauma care fellowship at the Alfred in Australia. He has recently completed training in conventional and minimal invasive spine surgery from Technical University Hospital in Munich, Germany. Dr. Agarwal was a senior registrar and then assistant professor in the Department of Neurosurgery at Grant Medical College and Sir J.J. Group of Hospitals. He has worked as a consultant neurosurgeon at various hospitals, including Fortis Group, Maharaja Agrasen Hospital, Punjabi Bagh in New Delhi, Baba Saheb Ambedkar Hospital, the Central Railway Hospital, and Jagjeevan Ram Hospital of the Western Railways. During his fellowship at the Alfred, he was awarded the Alfred Trauma Research Development Award for his work at that time. He has won the Best Dissertation and Best Research Paper Award by Research Society of the Grant Medical College, Mumbai, as well as Best Paper Award by Neurotrauma Society of India and Bombay Neurological Association. He has received several scholarships in his field of expertise. Apart from multiple presentations and publications in international and national journals and conferences, Dr. Agarwal has also done advanced research projects in animal experiments. Hemostatic effect of human fibrin glue on bleeding brain surface of Vista rats, and role of hyperbaric oxygen therapy in acute traumatic brain injury. So I would invite Dr. Vivek Agarwal to present his paper on how to manage severe traumatic brain injury. Dr. Vivek.
Thank you, Nadkarni sir, for kind introduction. First of all, I want to thank Arun Shah sir and whole organizing committee for giving me chance to present on this forum. So my topic is on the management of the severe head injury. Just a moment, let me start.
Yeah.
Thanks. So India is the capital of head injury because we have more than 2 million cases every year, which is maximum all across the world. And the almost 1.5 lakhs people dying because of the head injury. So we have every 6 to 10 minutes, there is a death of the person because of the severe head injury in India. And the bad part is that the majority of these patients, more than 90% of these patients, they don't receive a good pre-hospital care. And that results that 1 out of the 6 severe head injury patient in India dies compared to 1 out of 200 in US. So aim of the pre-hospital care in these head injury patients is prevention of second insult, and that is done by managing the blood pressure and oxygen saturation. So always in all these patients, the blood pressure should be maintained more than 90 millimeter of mercury and oxygen saturation more than 90%. The role of the first responder is very crucial in these patients. They should know how to take the IV access in these patients, and they should supply. They should give a supplemental oxygen if required, and they should be trained, which is not. I mean, which is away from the practicality, but majority they should know how to intubate these patients. Stabilization of the cervical spine is very crucial because 10 to 20% of these severe head injury patients has associated cervical spine injury. And while we are doing all these things, the first responder should inform all these information related to the patient to the hospital where the patient is going for further treatment, so that the whole team be ready for doing whatever is required for this patient. So at times the pre-hospital intubation is required in these in cases where the GCS is less than 9, if the patient vitals are dropping, patient is getting continuous seizure, or patient have an unstable mandible fracture, bilateral mandible fractures, or because of any other injuries like respiratory, pneumothorax and all, patient may be required to intubate while shifting to the hospital. This pre-hospital intubation is being controversial, and there have been study against and pros along with this. But overall, it has been seen that in cases where the first responders are experienced in intubation, patient where the sedation has been given to the patient, after intubation, if there is no hypo or hyperventilation given to these cases, at some time after intubation, there is a hemodynamic instability. So if these are managed well, the results are good in compared to cases where no intubation has been done. Once patient is in Once patient is in ER, then we follow the guideline of ALTS, where the patient is assessed and treated simultaneously. In case if the patient has signs of raised ICP like asymmetric pupil, patient having decerebrate response, or a decorticate posturing, patient having a Cushing triad, bradycardia, hypertension, or irregular respiration, immediately the treatment for high ICP should be started. As far as imaging is concerned, the CT scan is quick and gives all the relevant information about the head injury, whatever is required for early management in these cases. So CT is done in all these cases coming to ER, and along with that, we do a cervical spine screening because many of these cases have associated cervical spine injury. So always, along with the CT brain, the CT cervical spine is also done to rule out cervical spine injury. Cervical collar should not be removed until cervical spine clearance is done by CT scan. Follow-up CT of these patients is required in case if patient's GCS is dropping in ER. Even in cases where there is no drop of the GCS and the first scan is showing hematoma and the patient's GCS is less than 9 at the admission, a repeat CT within 6 hours should be done. Let's see a few of the cases. This was a 67-year-old lady. She came to us in ER with a history of fall at home. She was on dual antiplatelet for coronary angioplasty. And when she reached to our hospital, she was in decorticate posturing state. And the scan showed that the patient has a large subdural hematoma on the left side. So it was clear we decided to do urgent decompressive craniectomy on the left side with evacuation of the clot. But now because of the COVID, we have to do HRCT of all these patients. So we get a chance to repeat. This scan was done outside in different hospitals. So we got a chance to repeat the brain scan as well. And this was the scan of the patient. So she had a bleed in the brainstem. She got a diurate hemorrhage in the brainstem. Though our plan of the management didn't change in spite of this scan, but it gave us a better idea about the pathology and the prognostication of the patient. A recent patient we operated recently, 80-year male, history of fall with the dropping GCS. He came to our ER. Here in ER, he was intubated, and this is what the scan was showing. There were no fracture, but a diffuse bleed. On left side, there was large subdural hematoma with the midline shift. There was a subarachnoid hemorrhage, frontal bleeds, as well as bleed in the posterior fossa. So we decided to do a vascular imaging just to rule out that there is no vascular malformation or any other vascular pathology. So we did immediately, we did within after almost 30 minutes, we repeated the scan of the patient. We did a CT angio. So CT angio didn't show any kind of vascular pathology in this case, but what we found new in this scan that the patient is developing a subdural hematoma on the right side as well. So it was there already. A very thin subdural was there in earlier scan as well, but the new scan was showing a larger subdural hematoma. And in fact, if you see that midline shift was corrected because of this developing subdural hematoma. We took this patient, we operated, we did a decompression on the left side, large decompressive craniectomy was done. But we realized that the brain was bulging. On the left side, this brain was bulging out. And we had already had idea that the subdural on the right side is increasing. So one of our team member, he came out, he went to the relative and we told them that we are thinking, we have a feeling that that hematoma is further increasing and that is the reason that patient's bulge is increasing. So we did the craniectomy on the right side as well, and that helps in reduction of that bulging brain, and the brain become lax after the surgery. Another case, 32-year male, he was brought to our ER because of the road traffic accident. We got a call with this scan, and got a call saying that the patient neurological condition is bad. So there was a little clinical incongruency between the scan and clinical finding. So we went to the patient, we tried finding the history. So there was some suspicious history of seizure in this patient. Patient was loaded with the anticonvulsant. We waited for a couple of hours, but in spite of that, uh, patient neurological condition remained like that. So except for this, uh, his GCS on admission was 7. So this depressed fracture and this small extradural hematoma was not explaining the kind of GCS he had. So we repeated the scan after 2 hours. So this was the scan done at 5 p.m. and then we repeated another scan at 7 p.m. And this is what the scan was showing. He had a large extradural hematoma. So we took this patient immediately and we did a craniectomy, and the patient was saved. He improved significantly after surgery. So aim is to say that the injuries in first 24 hours in these cases are very, very dynamic. We have to be very careful. Close neurological monitoring is very crucial, and there is no option to it. We have to monitor these patients. We have to monitor these patients very closely. Any fall of the GCS, we need to scan, because if you don't scan, if you miss it, the very high chance that you may lose the patient. Even if there is absence of the clinical deterioration, or if patient is sedated, we need to repeat the scan of this patient within 6 hours, because what is happening inside you may lose if the patient is sedated, or where there is a hematoma, high chances first 6 hours the hematoma may increase in size. Another patient, this patient was shifted to our hospital after almost 24 hours of injury. uh, no surgery was done in the different hospital. She was brought here with the dropping GCS. There was a basal cistern effacement with a large contusion. So we offered doing surgical intervention in view of the worsening GCS. Relative agreed. So we did a large decompressive craniectomy on the right side. And after this was the scan after decompression. The basal cisterns were open up. In fact, there was little evolution of the contusions, but in spite of this result, the patient neurological condition remained like that. We ventilated her. We tried all the possible measures, but she remained same, almost same after surgery as well. So on the day 10th, almost, we did a MRI of this patient, and this is what MRI brain was showing. Dr. Darshana will present this case in more detail, just to show that this patient had a multiple large diffusion defect, and this is what the angio of the patient was showing, a vasospasm of all major intracranial vessels. Another patient, she 40-year female, a pillion rider on a bike, and she got a head injury because her dupatta got caught into the rear wheel of a bike, and she fallen down. And she was brought from Bohisar to our hospital with the decerebrating condition. We did immediately a large craniectomy on the right side. We decompressed, we removed the hematoma. And at the same time, we did a cystonotomy as well in this case. So we released the CSF from the base of the skull and we kept a catheter at the base. So this patient improved after doing surgeries. Day second, third, she started flexing and then localizing. But after that, there was stagnation in improvement. So again, we did an MRI of this patient and we found that patient had the multiple ischemic infarcts. Along with that, there was a thrombosis of the venous thrombus as well. And in angiography, we found that there is a spasm at the terminal end of the M1 on the right side, which was matching with the stroke. Another patient, this was a young guy, 37, had a road traffic accident. In fact, he was not in severe head injury category when he was brought to us. He was confused. GCS was 12. We started managing him with the medical management. With the anti-edema measure. He was all right till day 6. On day 6, this patient deteriorated. He became bad, and then we repeated the scan. In between, also, we repeated the scan. The scan remained stable, but on day 6, there was a large edema with the hemorrhagic transformation. And if you see, there was a clot in the sigmoid sinus. So this patient developed a thrombosis in sigmoid sinus. And not only sigmoid sinus, you see this is the difference in the CT brain of the patient. On day 1, superior sagittal sinus was all okay. On day 6, you can see thrombus in the superior sagittal sinus. And then we did a vascular imaging as well in the MRI. So it showed a thrombosis not only in superior sagittal sinus, but the both sigmoid sinus as well. So we operated this patient and he did well afterward. So aim is to say that it's not just the CT scan brain which is required in head injury. At times, we may require to do vascular imaging as well. And there is a Denver's criteria which shows that when vascular imaging is required in head injury cases. So if you have a neurological deficit which is incongruence with the head injury, with the clinical finding, so neurodeficit and CT scan is not matching, in those cases, we should look for the vascular changes as well. If patient has a focal neurological deficit like a transient ischemic attacks, he's getting vertebrobasilar symptoms, Horner symptoms, those cases also a vascular imaging become must, because we need to see what is happening there and whether it is. So we should not just look for the hematoma and edema. We have to keep in mind that there may be vascular problems as well in head injury cases. So these are the other cases where the vascular imaging should be done. I will not go in detail of this. So in severe head injury, these are the indication of doing surgical intervention. Extradural hematoma more than 30 ml with a midline shift, dropping GCS, subdural hematoma with midline shift more than 5 to 10 millimeter, traumatic intracerebral bleed with the pressure on uncal herniation, a depressed fracture where the fracture segment has gone below the skull vault. Posterior fossa EDH, here we keep a low threshold, even 20 ml of the extradural hematoma in posterior fossa, we need to evacuate. And if there is a diffuse edema with rise ICP, these are the common indication of doing surgical intervention in the severe head injury cases. Something about the decompressive craniectomy. Decompressive craniectomy we do in cases of head injury wherein we remove a large portion of the skull bone to reduce intracranial pressure. It is primary when we remove along with hematoma evacuation with anticipation that cerebral edema may increase. And it is secondary when we do just for a cerebral edema with a raised ICP. So in decompressive craniectomy, middle fossa decompression is very, very crucial, because that prevents the uncal herniation, and size of this decompressive craniectomy should be somewhere between 12 to 15 centimeter in size. Smaller craniectomy doesn't help. A generous durotomy is a very important step while doing a decompressive craniectomy, because that step helps in reducing the ICP maximally. So these are the steps of doing a decompressive craniectomy. We make a multiple burr holes, and then we remove a large portion of skull, and then we do a release of the dura, and that helps in reduction of the intracranial pressure in these cases. There are various trial has been done in head injury in these for the decompressive craniectomy cases. One of these is DECRA, where the results were not great. In DECRA, the mortality and morbidity after doing decompression in compared to medical treatment was poorer. But there was a problem in DECRA. Only secondary decompressive craniectomy cases were taken, and decompressive craniectomy in all those cases were done in very early stage. The second trial was the rescue ICP trial, where both the primary and secondary decompressive craniectomy were included. And in these cases, the threshold of choosing the cases were very high, and even the surgery was done up to day 10. So the results in rescue trial were better in comparison to DECRA. Here, not only the mortality, but there was functionality improvement as well in these cases. So in 2020, there is an update. There's a Brain Foundation trauma recommendation on the decompressive craniectomy. And as per this new update, secondary decompressive craniectomy performed for late refractory ICP has a good outcome. They not only prevents mortality, but they have a favorable functional outcome as well. While the secondary decompressive craniectomy, when it is done for early refractory ICP, these are the not cases where the hematoma is there. This is only for the generalized cerebral edema. So when secondary decompressive craniectomy done in early refractory ICP elevated cases, the results are not great. And always whenever decompression has to be done, the bone flap size should be more than 12 centimeter in size. Something about cystonotomy. Nowadays, when we are doing decompressive craniectomy and we see that the brain is too much edematous, in those cases, we go to the base of the skull and we release the CSF. And we wash out the subarachnoid hemorrhage, because all these cases, they have subarachnoid hemorrhage. So we do cystonotomy, we take out the blood from the cisterns, and washing out this blood from the skull base helps in reviving the CSF circulation at the skull base. So because of this subarachnoid hemorrhage at the skull base, it causes interstitial edema into the brain. Once you do cystonotomy, you take out the blood from the cisterns, the intracranial pressure comes down. And this is what we do with the cystonotomy. So this is a small video just to show how we do cystonotomy. So first we do decompression of the brain, either with the hematoma evacuation or just with the removal of the bone flap. And then we retract the frontal lobe and we go to the base of the skull. You see, this is optic nerve, and we are opening the optic cistern here. I will just fast forward the video. So we are opening the interoptic cistern here. So we open all these cistern at the skull base. Like Dr. Rajan Shah showed for the aneurysmal surgery, we do same thing here in the skull, in the head injury. We release the CSF and wash out the subarachnoid hemorrhage, and this decreases the intracranial pressure significantly. And after surgery, we keep a catheter at the skull base. So this catheter will keep draining the CSF, and not only draining the CSF, we can measure the intracranial pressure of the patient as well with the help of this. So here, see, we are opening the interpeduncular cistern by opening the Liliequist membrane. So this is an example. I just already showed you that lady with the road traffic accident. She had a large subdural hematoma with the midline shift. We did a cystonotomy along with the decompression, and she improved significantly after doing this procedure. So cystonotomy we keep as a standby whenever in spite of doing decompression, the brain bulge is too much. In those cases, we do it. So doing surgery in these trauma cases looks simple, but it is not. It's an example. This is 67-year male. He was brought to us with a poor neurological condition. He had a large subdural hematoma on the left side. So we took this patient, we did a decompression on the left side, we evacuated the clot. But while evacuating the clot, we realized that brain bulge is out of proportion. And immediately after closure, we shifted the patient to scan, and this is what the scan of the patient was showing. So we evacuated the clot on the left side, but this patient was developing subdural hematoma on right side as well. So we took back this patient to OT and we removed the clot from the left side, and that helps in saving the life of the patient. So it is not just the surface of the brain we have to see while doing surgical intervention. We have to realize what is happening behind the surface or on opposite side as well while operating, because it's too dynamic, it's too changing things. So repeat scan is always helpful. If you have a portable CT in OR, that's very, very helpful in taking decisions for these patients. Another example, this patient is still in our ICU. So patient had a 70-year male, had a subdural hematoma. We did a decompression on the left side, and after brain was lax after evacuation, and we closed it. But within 15-20 minutes, we realized that the flap tension is increasing. The flap was very tense. So we shifted this patient to scanner, and this is what the scan was showing. He was having a large evolution of the contusion on both the frontal side. So we kept the patient in ICU on the other anti-edema measures, and this patient is improving now. Spontaneous eye opening is there, but So the aim is to tell you that the pathology, the injuries are very dynamic, and we have to anticipate not only on the, we have to see not only on the surface, but we have to think what is happening behind. We have to keep measuring the ICP of these patients and keep doing a repeat scan to find out what is happening. And clinical examination is very, very important in these cases. So once patient is in ICU, they should be nursed in propped up position. Generally, we keep the propped up position up to 30 degrees, and this is the graph showing that the drop of the ICP with the elevating bed level is up to 30 degrees. Beyond that, the drop of the ICU is not ICP is not that much, but it decreases the perfusion pressure of the brain. So we should not increase the propped up position beyond 30 degrees. The neck should be straight because turning of the neck cause the engorgement of the veins in the brain, and it cause more swelling in the brain. As far as fluid management is concerned, and there are multiple sessions after my talk, they will talk more in detail, but the 0.9% saline is the best fluid for these cases. We prefer giving hypertonic saline in these patients for reducing ICP in comparison to mannitol because it has a reflective index of 1, so leak chances are less. We try to maintain the sodium somewhere between 145 to 150 with the, and we repeat electrolyte in all these cases at every 4 to 6 hours. All these patients after surgery we keep on or even if no surgery has been done, we keep them sedated and we ventilate them. And analgo sedation is the guideline which has indicated for giving in these cases. There are two kind of analgo sedation. One is the analgesia first sedation where the fentanyl or opioids are given along with the sedations, and second is analgesia based sedation where only opioids are given, but overall results of the analgesia first sedation is good and we follow that in our institution. So all these patients have a high risk of seizure. So risk of seizure is up to 30 degree, 30%. So these patients should be given either Aptoin or levetiracetam. The risk is high in the first 7 to 14 days. So we follow giving the anti-epileptic for this time. It doesn't prevent the seizure in late stage. So late stage, only high risk patients are given the anti-epileptics. General management, these patients should be, their position should be changed at a frequent interval because of chances of developing a pressure sores. These patients, many a time, they are very irritable. So we need to restrain this patient either with the physical mean or by medical mean. But we have to be careful while doing physical restraint because there are many cases of gangrene or other damages because of restraining, and a proper consent has to be taken while before restraining these patients. Peripheral nerve injury in ICU is a common thing that we have to be careful. We should pad all those peripheral nerve points very well so that they should not develop a peripheral nerve injury. DVT is again a important topic, which I feel coming talk will in detail, they will discuss about the DVT prophylaxis. But here we immediately after, once the patient is shifted to ICU, we start the intermittent pneumatic compression device. And once we have two stable scans where there is no progression of the hematoma, we start LMW heparin in these cases. Early institution of enteral feeding is recommended in these cases because it reduces the risk of ICU pneumonia, it reduces the risk of bed sore. So as early as possible, we start enteral feeding in these cases. I will skip these all things, which because I think further talks are on this. Neuro rehabilitation is definitely a backbone of management. In these cases, we involve neuropsychologist, we involve swallowing speech team, we involve occupational therapist and physical therapist for management of these patients, and we give a customized care to these patients so that according to whatever damage they have, we give neuro rehabilitation and we try to get the best outcome from the patient. Thank you.
Thank you, Dr. Vivek. We are already a little over time, but we could take a couple of questions if there are any questions.
I think Dr. Nadkarni will move ahead because already we are late, and the audience can communicate with the individual faculty as per their.
That's fine. Let's go ahead. So we'll conclude this first session.
If you can just wait for a few minutes, we'll have a inauguration ceremony. Our CEO, Dr. Tarang, is here. So.
So now we'll have the inauguration by our CEO, Dr. Tarang Gyanchandani ma'am. She's done her MBA in Healthcare Management from National University of Singapore, Clinical Fellowship in Orthopedics from Alexandra Hospital, Singapore, and MBBS from Lady Hardinge Medical College, New Delhi. Dr. Tarang ma'am has vast experience both national and international in acute and long-term care operations as well as multi-site management in private and public sector. She completed her MBA with specialization in healthcare management from National University of Singapore. In addition, she completed specialization in orthopedics in Singapore and MBBS from Lady Hardinge, New Delhi. Prior to joining RFH, she's been the CEO of Jaslok Hospital. Before Jaslok, Tarang ma'am has worked with Ministry of Health, Hospital Services Singapore, Changi General Hospital Singapore, National University Hospital System, Alexandra Hospital Singapore, Lok Nayak Jai Prakash Narayan Hospital, and GB Pant Hospital in New Delhi. She has been felicitated with numerous awards: Award for the Best Multi-Speciality Hospital and CEO for the year 2017, Women CEO for the year 2016, Best Business Leader Award for CEO, Health Excellence Award in 2015 and 16, Rashtriya Vibhushan Award in 2016, and Rashtriya Ratan Award in 2015. She believes in developing sustainable health care systems in healthcare organizations with a prime focus on quality patient care services and clinical outcome. She is confident that a good clinical and management team with strong and dynamic leadership can achieve the best patient outcomes and quality care in the hospital. And that's what she does. I'll just welcome her.
Thank you very much, Dr. Divya, for your kind introduction. A very good evening to everybody. And dear friends, colleagues, I would first of all take this opportunity to thank you all for being a part of our stroke and neurocritical care conference today. I would also like to share today a good news that our neuroscience department has been acknowledged as a center of excellence by the Times Healthcare Leaders Award yesterday. I would like to congratulate entire team of neurosciences as well as uh, our director for neurosciences, Dr. Arun Shah, as well as all our multidisciplinary teams, our Department of Critical Care with Dr. Mayur Patel as our director, as well as all our intensivists, and the entire team of rehab who work together with our neurosciences team and help us to achieve a success. As you all know, and I'm sure you are much more aware and are working towards it, we acknowledge that stroke is one of the major causes of mortality worldwide, and it commonly occurs amongst the elderly. Indian population is relatively young compared to the West, but stroke in India has already attained an epidemic proportion. And during the pandemic of COVID, we further saw that how this virus also had impact in increasing the number of strokes. We have also observed that it is not only the elderly, but it is also the younger population which gets affected by stroke very regularly. Why the hospitals, why the country, why the state, and why all of us are here today, and why do we need to worry about stroke? The reason is that it's not only a crucial health issue, but because of the fact that it may or may not cause the death of the patient immediately and leaves the patients with several residual disabilities like physical dependence, cognitive decline, dementia, depression, and seizures. The cost involving the care of these patients gets enormous and has adverse social implications as well. Hence, I think a quick control of the epidemic of stroke is as crucial as controlling the pandemic of COVID. We are proud to share that during the COVID pandemic also, our multidisciplinary team at Sir Adrian Reliance Foundation Hospital could achieve the benchmark of the door to needle time mostly ranging between 37 to 90 minutes, and achieve the best stroke outcomes possible. We did see a very steep increase compared to the previous years in the number of stroke from July till November. And I'm really proud to share that our team here was able to manage against all odds of COVID the best outcomes for these patients. This conference is organized to provide an overview and arrange a discussion platform amongst all of you on the recent updates and the practical issues surrounding the delivery of the state of the art stroke care. I'm sure through your lectures, case presentation, and interactive discussions, this conference will explore the critical issues surrounding the assessment, management, treatment, and prognosis of stroke in the acute, subacute, and non acute settings, with the emphasis on risk assessment, prevention, and monitoring according to the latest stroke guidelines and in consideration of special circumstances such as COVID. I'm sure we are here today and tomorrow, and we learn from each other to ensure that we get the best outcomes for our patients together. In the end, I would like to wrap up by mentioning that COVID-19 pandemic is surely a public health emergency worldwide and a priority for healthcare in the current times. But we should also acknowledge that acute stroke is a time sensitive emergency and requires prompt recognition and treatment to reduce the morbidity and mortality. So let us all work together to help the patients of acute stroke and remind them that they need to reach the hospital as soon as they recognize their symptoms, and do not stay at home worrying only about COVID. And I think it is the prime responsibility of all the hospitals to ensure that their multidisciplinary teams are given the best support to deliver their services to their best to salvage these patients and achieve favorable outcomes for the patients. So I wish all of you all the very best, and I'm sure we will together make sure that we are able to identify more and more of our patients and do the best for more and more of our stroke patients. Thank you very much. Have a good evening.
Yeah, I must thank Dr. Tarang for waiting so late for participating in this symposium, and with our, I think, constant encouragement, we perform better and better. Thank you very much, ma'am. So I thank Dr. Nadkarni and Dr. Zirpe for spending time and in chairing this session. And I think since the time is short, we'll move on to the next session.
We'll start with session 2. The chairpersons for session 2 are Dr. Rahul Kulkarni and Dr. Mayur Patel, sir. Dr. Rahul Kulkarni is the head of neurology department at Dinanath Mangeshkar Hospital, Pune. He's trained in neurology at TN Medical College, Mumbai. He is the secretary, tropical neurology subsection of Indian Academy of Neurology. Member of many international and national neurological organizations. He's a faculty in many international, national, and regional meetings. 12 publications, 2 book chapters, principal investigator in more than 25 multi-center trials in neurology, actively involved in training practitioners and students. Special interests are CNS infections, neuroimmunology, and neurology education. Yeah. Next is Dr. Mayur Patel, sir. He's the head of critical care medicine and emergency medical services at Sir H.N. Reliance Foundation Hospital and Research Center. After completing his MD, he successfully pursued Rajnandan Pulmonary Disease Research Trust Fellowship from Royal Devon and Exeter Hospital at UK. Thereafter, he completed fellowship at the American College of Chest Physicians, USA. In his rich experience spanning 27 years in critical care medicine, Dr. Patel has served in various capacities at reputed institutes, Cefi Hospital, Jaslok Hospital and Research Center, Tata Memorial Hospital, and now Sir H.N. Reliance Foundation, to name a few. With more than 25 scientific papers to his credit, more than 36 major talks by invitation at various conferences, symposia, workshops, Congress meetings, and 8 poster presentations, Dr. Patel surely has an illustrious career in critical care. He has had critical positions such as chairman of the organizing committee, joint secretary, etc., for conferences on multiple occasions. Dr. Patel also has vast experience in training and is the teacher for fellowship in critical care, National Board, Delhi, teacher for certificate course in critical care medicine, and teacher of diploma and fellowship in critical care medicine for Indian Society of Critical Care Medicine, teacher for diploma in chest and chest diseases under the auspices of College of Physicians and Surgeons. I welcome them to start the second session.
So thank you very much. Do we start with the second session? Can we have the first slide?
Yeah.
The first. Yeah.
Dr. Rahul, should I start?
Yeah, you can start.
Yeah. Dr. Mehul Shah is going to speak on ventilatory management in acute brain injury. Mehul has been with us since the inception of this hospital, has been trained extensively in critical care in India as well as in the Australia, and has special interest in neurocritical care, and that's why this topic for him. Over to you, Mehul.
Thank you, sir. At the onset, I'd like to thank Dr. A.B. Shah and Dr. Mayur Patel for this opportunity. And I'd like to start. The topic is ventilatory management in acute brain injury. And I will try to make it case-based oriented and put forward some guidelines. I'll take you all through to guidelines and certain evidences and certain things that we have learned over the last few years. So my talk is going to be talking about things with intubation, ventilatory strategies when it comes to raised ICP measures, ARDS in acute brain injury, weaning, tracheostomy, and decannulation. So I'll start with the case. I have a 65-year-old male presented to the emergency department drowsy, left-sided weakness, body of the body, facial deviation, slurring of speech, all since 5 hours. GCS was E2, M5, V3, NIH was 15, bilaterally reacting pupils, sinus rhythm at around 60, blood pressure hypertensive at 188, saturating 94 on room air. Non-contrast CT shows a massive right MCA infarct. Course of management, he was maintaining his airway, had a weak cough, had regular respiration, SATs became 98 with 4 liters of oxygen, pressures came down to around 170, deferred thrombolysis, had a GCS of 10 by 15 with regular NIHS scoring, labs were sent, X-ray was clear, commenced on IV fluids and nasogastric tube was inserted, sugars were well controlled. He had a past history of stroke, diabetes, and hypertension, but no allergies. Within the next 12 hours, he dropped his GCS to around 7 by 15. Antihypertensive measures were started, dropping his blood pressure down. Anti-edema measures were started. Coagulation profile was kept on a check, and an urgent neuroconsult was given. So now we've come to this patient who'd come in with a GCS of 10 and now has dropped it down to 7. He's definitely going to be requiring some amount of airway protection. So let's go through some of the guidelines. One of them are from the European Society of Intensive Care. These are 2020 guidelines. And let me just take you through the important points. So what are the indications of endotracheal intubations in acute brain injury? Very simple. All patients that have a lower level of consciousness, severe agitation combative, loss of airway protective reflex, and a significantly elevated ICP has a strong recommendation for getting intubated. Is there a role of NIV or high flow oxygen? So the guidelines say that they are unable to provide us with any recommendation with the use of NIV, especially when the patient who has hypercapnic or a mixed hypercapnic and hypoxic respiratory failure. This suggests that you can use high flow. However, it must be ruled out whether there are any contraindications and the patient should be tolerating it. So we decided to intubate this patient. What would be our initial ventilatory settings? So the recommendation for mechanical ventilation in acute brain injury who do not have clinically significant raised ICP, you can use the same level of PEEP without, like the ones you're using it without brain injury. So PEEP can be used. Second recommendation of mechanically ventilated patients who have clinically significant ICP, raised ICP. In those cases, you need to know whether this patient is PEEP sensitive or PEEP insensitive. When we say PEEP sensitive or PEEP insensitive, we mean whether increasing the PEEP is going to increase the ICP. Yes, it's but obvious that these patients generally require ICP monitor. And in these patients, it's very difficult for us to understand whether that increase of PEEP is going to be increasing the ICP without these monitors. The other recommendation is mechanically ventilated patients who have ARDS and who do not have clinically significant raised ICP. We can use lung protective mechanical ventilation. However, the suggestion, they say that we suggest the patients on mechanical ventilation with acute brain injury without clinically significant ICP for strategies to be used like lung protective ventilation. They are unable to give us any recommendation when it comes to protective lung ventilation with acute brain injury in patients who have a significant raised ICP. So protective lung ventilation is something what we do in ARDS, low tidal volumes, keeping the plateau pressures less than 30. And there is a use of a higher PEEP. There is a allowance of permissible hypercapnia. That's why these things are important to be. They're again unable to provide us recommendations regarding protective lung ventilation in mechanically ventilated patients who have concurrent acute brain injury, ARDS, and a significantly raised ICP. All right. So what did we ventilate our patients and what will be our targets? So he was ventilated at a tidal volume of 500. Idle body weight was 65, respiratory rate was 16, FiO2 was 55, and a PEEP of 5. Let's see if that was adequate. We had a pH which was 7.35, a PO2 which was 75, and a PCO2 which was of 45, and an end-tidal carbon dioxide of 48. Patient was sedated, paralyzed, and on mechanical ventilation. So what are the recommendations by the society when it comes to these values? So they recommend the PO2s to be kept anywhere between 80 to 120, whether or not the patient has clinically significant elevated ICP. Now, they recommend the target optimal PCO2 who do not have raised ICP to be kept anywhere between 35 to 45. They recommend hyperventilation as a therapeutic option in patients who have a brain herniation. The recommendations for hyperventilation they are unable to provide when there is concomitant, significantly raised ICP and acute brain injury. So what would you do when this patient then develops this? You do these managements. A short mnemonic, which is heads, is avoid hypertension, avoid hypoxia, avoid hypothermia, and avoid hyperglycemia. Elevate the bed, as Vivek was talking in the previous lecture, to around 30 to 45 degrees. Avoid agitation, adequate sedation, use drugs, and prevent DVTs. So now the most important concept is of carbon dioxide, because as we all know that alveolar ventilation is inversely proportional to the carbon dioxide which we have. In simple line, if you increase the alveolar ventilation, you decrease the carbon dioxide. And one important thing I'd like to bring forward is carbon dioxide is carried. It's a diffusible gas and it is carried in the blood with three ways. One is dissolved in the blood. Two, by 20 to 30% bound to the plasma protein and the hemoglobin. And most importantly, 60 to 70% is converted to carbonic acid in the red blood cells and the plasma. And this third complex is very important for us, and we'll understand that later. So let's understand what happens with CO2 and the cerebral physiology. CO2 reactivity is the ability of the cerebral resistance arterioles to dilate or contract with the changes in the CO2. So if you all see this graph, there is a specific range between which these arterioles will either dilate or contract, and hence will either increase or decrease the cerebral blood flow, in turn will increase or decrease the ICP. Now let's understand, as we said, dilatation happens when the CO2 increases and contraction happens when the CO2 drops, that is hypocapnia. A normal brain blood volume is around 3 to 4 ml per 100 ml of parenchyma. 70% of the blood volume is in the venous system. That means 30% of it is in the arterioles. So 30% of what we are able to manipulate will drop the ICP or the cerebral blood flow by 7%. So we need to understand that you have a control over 30% of the circulation, and that if you are able to bring down the CO2 at the right time, you will be able to reduce the cerebral blood flow. Hence, you will be able to reduce the ICP. So hypercapnia triggers vasodilatation and leads to increase in cerebral blood flow and increases the ICP, and vice versa for hypocapnia. Importantly, when you use hypocapnia, you are triggering a lot of cerebral metabolites, increasing the seizure threshold, and can potentiate or prolong convulsive activities. Nevertheless, when you induce hypocapnia, it is at the price of causing tissue hypoxia. And four important methods in which it causes tissue hypoxia. One, it decreases the cerebral blood flow and it will cause ischemic hypoxia. Two, it causes a response in the lung, which is called as hypoxemic hypoxia. Three, because of the washout, it causes the leftward shift of the oxygen dissociation curve, and hence higher affinity of oxygen for the hemoglobin, and hence hypoxia. And because of the neuroexcitatory hormones which are there, it increases something called as CMRO and hence leads to tissue hypoxia. So here we are seeing it, cerebral blood flow, decrease CO2, decreases cerebral blood flow, decreases cerebral blood volume, decreases ICP, increases metabolism, but has a decrease in cerebral oxygenation too. So let's understand certain studies and what timings can we use this. So it's very important to understand that whenever you're using cerebral hypocapnia, this cannot be used for a long period of time because the CO2 dependent, the cerebral arterioles are dependent on the perivascular pH, which gets normalized whatever you do within 6 hours. So clinical studies have demonstrated that 40% decrease in the cerebral blood flow will happen at a PCO2 of 40. but within 4 hours, they will start normalizing. So it is not beneficial to keep hypocapnia on for a very long time. CO2 also, when you are getting out of hyperventilation or hypocapnia, you need to realize that you need to do it slowly, because that will lead to a rebound hyperemia because of local acidosis and again vasodilatation. Studies show, 2 small studies have been conducted and show mortality and poor neurological outcome when we've used hyperventilation. Gordon showed a large prospective study where they used prolonged hyperventilation. They found a lower mortality, but however, the neurological sequelae at the end of 6 months was not that great. Another prospective study using 3 different groups in which they used a THAM, which is a buffer, showed better outcomes at 3 to 6 months. But you need to realize when and how to use cerebral hyperventilation. So a very simple algorithm. You have worsening neurological signs and symptoms in the form of drop of GCS, asymmetry of pupils, seizures, herniation syndromes, or you have a raised ICP, which you are picking up with a plateau A wave, refractory ICP or hyperemia. Then you are able to induce hyperventilation where you target a PCO2 of 30 to 34 or an end tidal carbon dioxide between 25 to 30, but as a temporizing measure before you land up for a scan or before there is a surgical intervention. So we know how to do it. Let's know when not to do it. What is the evidence? Cochrane says that there isn't sufficient evidence which clearly establishes the role of hyperventilation syndrome in the management of severe traumatic brain injury. The Brain Foundation, the Brain Trauma Foundation talks about a brief period of hyperventilation for 15 to 30 minutes just as a bridge to treat acute deterioration reflecting in raised ICP. If that doesn't work, then they suggest to use osmotic therapy, paralysis, and other methods. So this is a simple chart which gives you the 6 don'ts of when not to use hyperventilation. Do not use it prophylactically. Do not use it in the first 48 hours, chiefly in the first 24 hours, because the first 24 hours, the cerebral blood flow have been damaged or been changed, altered because of either the large stroke, either the trauma, either the raised ICP. Do not use it without raised intracranial hypertension. Do not use it for a prolonged period of time. Try not to use it without using SJVO2 or brain tissue hypoxia measures, and do not stop it suddenly. So these are the guidelines by the Brain Trauma Foundation. And as I've highlighted, it just says prolonged prophylactic hyperventilation is not recommended. Let's understand how will we manage other patients. You get some patients who come in with this. You have a massive brain hemorrhage, massive infarct, and you've got ARDS, and you have acute lung injury. And as high as 30% of these patients with severe brain injury come with acute lung injury and ARDS, and that has a poor outcome. So let's understand how do we manage ARDS with acute brain injury. We've been conventionally taught about ARDS, and there are n number of papers, but we are sometimes reluctant to implement this knowledge in brain injury patients. Why? Because there is a conflicting paradigm. Historically, we've been trained that brain-directed strategy is optimize oxygenation, control the carbon dioxide, and minimize the potential effects of PEEP. And lung-protective strategy talks about avoid overdistension, open the lung, use good amount of PEEP, and prevent cyclical opening and closing. So there is a conflict. Let's understand what are the 2 most important things for us. What really matters to the brain and what the brain really wants is just oxygen and adequate perfusion. So if you avoid hypoxia, you protect the cerebral perfusion by avoiding hypotension, avoiding raised ICP, and by avoiding inadvertent use of hypocapnia. So let's understand CO2. We've heard a lot about CO2, but the most important point of CO2 is that if, like in ARDS, we use permissible hypercapnia, the concerns of permissible hypercapnia in a traumatic brain injury or in a acute brain injury are the causes that it leads to acute hyperemia. It increases the ICP, especially when you have a very low compliance system. So this is what I'm trying to explain. If you look, a good amount of change in the volume of the brain does not increase the pressure so much. However, on this part of the curve, a little change in the volume of the brain with blood or cerebral edema will dramatically increase the pressure. This is very important to understand. So we come to another topic of PEEP. There is a lot of debate with regards to it, and people are reluctant to use PEEP. As we said, you can use PEEP if there isn't raised ICP. If there is raised ICP and you are not sure, on that you have a patient with acute ARDS, you need to realize that what will PEEP do? A high level of PEEP may be bad for the brain. Why? Because it decreases the venous return. There is a transmission of intrathoracic pressure which can increase the ICP and also reduce the cardiac output, which in turn will reduce the cerebral blood flow. So let's understand why PEEP does not majorly affect the ICP. Cerebral circulation has something called as a Starling's resistor. In a simple language, what it means is cerebral perfusion pressure is nothing but mean arterial pressure minus the ICP. If your PEEP does not affect your CVP enough to rise above the ICP, you do not have a problem in using PEEP. Other important thing, like what my colleagues said, head up. If you see this patient in a supine position and you see this patient in a head up position, if you apply a good amount of PEEP, because of this position, there is a diminished effect of the intrathoracic pressure due to the decreased transmission of the right atrial pressure to the head. Hence, your PEEP is not going to be affecting your CVP that much, which is hence going to be going above your ICP and then affecting your cerebral perfusion. So, PEEP is usually well tolerated in patients who use it. A moderate amount of PEEP is associated with little changes in the cerebral perfusion as long as the mean arterial pressure is maintained, as long as you've kept the patient at 30 to 45 degrees, and don't forget about the CO2. So the bottom line is you can use PEEP, ensure that there are no changes in the mean arterial pressure with adequate intravascular volume, keep the head up, follow the ICP, and consider maintaining the PEEP less than the ICP. Now I'll move ahead from ventilation towards extubation. So there were a couple of studies, and one important study which I came across saying that trying to delay extubation till you get a neurological recovery does not help, because it increases your chances of VAP, length of stay, cost, and then ultimately it changes the morbidity and mortality. So if you have a patient who's less than 40, who on the day of extubation or you've planned extubation has a visual pursuit with you and is able to track you in the room, he has an attempt to swallow, a GCS well of around 10. Based on these 4 items, there was a predictive score of which is called as Visage, and they said that if you use this has a 90% chance of successful extubation. Other points for extubation, in short, maintain the patient in a negative fluid balance, have an adequate cough gag, and this Visage score. We move on to the other thing that we generally do with our patients over a period of time, the patients going on to tracheostomy in acute brain injury. So the debate will always remain whether you do early or late. In our institute, we've been started following and we've been doing a lot of early tracheostomies and found a good association with decreasing the amount of ventilator days. A monocentered retrospective studies in trauma patients showed that it decreases the chances of pneumonia and decreases the length of stay and gives lesser days on the ventilator. Another retrospective study of 1,800 patients supported early tracheostomy. However, between early and late, mortality benefits were not great. So in clinical practice, early tracheostomy may not be recommended, but could be considered in situations where there is a high risk of extubation failure, like infratentorial lesions, protracted ventilations, patients who have a poor neurological recovery, and who you think are going to fail extubation. Lastly, I don't think so my slides will be complete if I do not talk about decannulation of tracheostomy. There is a very simple checklist what we put forward for decannulation: intact sensorium, successful prolonged spontaneous breathing trial the patient has passed through. Characteristics of the secretions are minimum. We generally look at something called as a tracheostomy count. And I remember sir always on the rounds asking me always one question: Mehul, how many in a day? If it's less than 10, he gives me a thumbs up. There's an effective swallowing, there is an effective cough, patent airway. You need to realize whether this patient falls into a shorter duration of ventilation or whether he had a longer duration of ventilation with neuromuscular weakness. In those cases, you can probably think of downsizing, blocking, and then seeing if you want to decannulate. In other cases with shorter duration of ventilation, you can think of something called as a corking trial. And then if that fails, then you can probably think of extending the TP's trial and then readdress it later on. I shall end over here. Thank you.
Thank you. Thank you, Dr. Mehul. It was a wonderful talk. So now I think we'll move to the next talk. The next talk is going to be by Dr. Arun Shah. And everyone in the audience probably would know Dr. Arun Shah. He's a director of the Department of Neuroscience at HN Reliance Hospital. And he's been the PG teacher for many years, more than 35 years. He's been in the field of neurology. He's been teacher for many of us, including myself. He was trained at KEM Hospital. Then he was trained at Oregon. And then thereafter, of course, he worked in multiple hospitals. Now, of course, he's running the Stroke Ready HN Foundation Hospital, as well as he's running the multiple sclerosis clinic at Reliance Hospital. And he's going to talk on a topic which is pertinent for day-to-day activity today, about the neurovascular conflicts during this COVID pandemic. Over to you, sir.
Thank you, Rahul, for kind words. And I think you are more expert in this field than I am now, because Dr. Rahul is an infectious disease expert and he's very active in Indian Academy of Neurology in that. So what I'm going to do is, of course, the COVID pandemic is receding and people are losing interest in it. But for the last 6 months, so much of literature is there on this topic that I thought I would review some of them, and maybe the controversies which are arising in the literature about relationship of COVID and stroke, probably, and what we can learn out of this. And that was for our neurology itself is my aim of the talk. So this is my outline. I'm good introduction. Then maybe I'll present some case vignette, then discuss about COVID-19, stroke, evolving story, and RFH data. Then, of course, the COVID has opened up our eyes to what is the role of day-to-day infection in relation to stroke morbidity, stroke mortality, and occurrence of stroke, and also discuss about other neurovascular complications, and then some interesting case of concurrent infection, COVID-19, limbic encephalitis, and GBS, which I'm going to show. So the prevalence of neurologic findings, if you go by literature, it varies from 3.5% to 84%. So we can't make meaning out of this statistic, so much of a range. So it probably depends on which particular question, which particular population you are studying. So the various coronavirus related neurological disorders included, just to list them, is encephalopathy, anosmia, altered test, headache, stroke, seizures, acute necrotizing encephalopathy, hypoxic ischemic injury, encephalitis, and demyelinating polyneuropathy. And of course, there are other things which are mentioned. Now, this is the recent prospective study, and maybe probably this will be more reliable than there's a wide range which they have talked of. That they prospectively studied 4,400 hospitalized patients. So they came out with a figure of about 13% of neurological disorders. And the commonest neurological disorder was toxic metabolic encephalopathy, was about 7%. Stroke incidence was about 1.9%, and majority of them ischemic, and only 0.4% was hemorrhagic. Subarachnoid hemorrhage, I don't know how they link to that because I'm not sure, but it was only 0.1%. Seizures, 1.6%, and that's a statistic. Many other papers have got it. Hypoxic ischemic brain injury is about 1.4%. Movement disorder, particularly worsening of Parkinson's disease, and there are some reports of akinetic rigid syndrome in about 0.9%. Neuropathy, myopathy, Guillain-Barré syndrome, and of course variations of Guillain-Barré syndrome such as Miller-Fisher syndrome, and of course the autonomic neuropathy is also described. They did not find in their series encephalitis or meningitis or myelitis or myelopathy, though there are isolated reports in the literature on that also. So how does the nervous system gets involved by SARS-CoV-2 virus? And there are various uh, postulations that it could as well be direct infection and direct spread through axonal pathway from the cribriform plate also can occur, or maybe it could also neuronal pathway from vagus nerve endings in lung and GI tract. If the infection is there, can also lead to spread of virus into the brain. The hematogenous spread is of course there because ACE2 receptors, the angiotensin converting enzyme 2 receptors, are present in glial tissue, neuron, and the brain vasculature. Finally, of course, the immune mediated, and that is much more makes sense, cytokine storm and immune thrombosis, hypoxic injury, and there are various probably mechanisms which we have still not understood, maybe involved in the pathogenesis, and there's just a schematic drawing which suggests that you can have axonal pathway through cerebellum fluid, or you can have axonal transport through the vagus nerve endings and sympathetic fibers from the lung parenchyma going into the brain stem. Now, what are the different neurological manifestations which already I think I have listed? So I'm not going to repeat all those things. Just to mention that the story of stroke and COVID is still evolving, and maybe the earlier reports may not be confirmed by future experiences, which is I'm going to emphasize by from our experience. And there are other things which we saw recently is recurrent myelitis and autonomic neuropathy are two more neurological manifestations which we experienced in recent past, and I would probably mention that here. This is of course the approximate timeline. So the interesting point is that the GBS, which is mentioned as a post-infective disorder, probably sometimes is seen in acute phase itself in relation to COVID, like their pre-monitory phase or pre-incubation period, and then this period. And so by the time you have 7-8 days, sometimes GBS have been described right that is a little fun, interesting phenomena. Similarly, myelitis, encephalitis, edema, all these complications are described very early in the COVID as compared to what we believe that is a post-infectious or para-infectious should occur with a latent period. And that is interestingly shown by this schematic graph, which shows that when once you have you are exposed, the clinical manifestations will start of the COVID clinical presentation, and you may have the complications coming up light, particularly stroke can be seen right from day 3 or 4 with the COVID infection. So this is interesting point from this particular slide. So I'll go to my first case, which is a 30-year-old man with diabetes and present into our emergency with the left hemiparesis, drowsiness, vomiting. He came to us, unfortunately, almost after 10 hours. This was the case during the peak time on July when beds were very difficult. So he kept on moving around with various hospitals and ultimately landed up in our ER after 10 hours from the onset of a stroke. In addition to stroke, he also had low BP, he was hypoxic and required high O2 to maintain his saturation. He underwent immediately CT brain and CT chest, and CT brain showed a large already changes of MCA infarction with aspect score of 0 and with hypertense MCA. So we knew that his MCA was occluded. He had only risk factor was diabetes. His CT chest surprisingly did not show any evidence of SARS-CoV pneumonia. A 2D echo done showed generalized hypokinesia, suggesting that he had cardiomyopathy. His serum creatinine was high, and his transaminase was high, suggesting liver dysfunction. So he had all the features of systemic inflammatory syndrome adult variety with right MCA occlusion. And this is what his showed. And he's probably there was MCA hyperdensity, the right MCA was occluded. So he was probably tachypnic. So he was initially supported on NIV. He was on triple vasopressus for his cardiogenic shock and septic shock. He had oliguria. He had to be and metabolic acidosis. So he had to put on CRRT with the heme absorption cartridge or cytosol filter, which was changed every 24 hours. He was later intubated, and as expected, his GCS dropped within about next 24 hours, and he underwent decompressive craniotomy to reduce pressure. And this was his first scan, the second scan, and of course, this is the surgery. And with the management over the next 7 days, his for inflammatory markers kept on falling. The interleukin 6 fell, the D dimer fell, and the ferritin level also back to normal with heme absorption filter and dialysis. In addition to stroke, he also had microangiopathy involving his fingertips and also the toes, and probably this worsened later on. And this, of course, may be combination of factors that he was on triple vasopressor support, plus, of course, the immune thrombosis must have affected microangiopathy as well. So next 3 days, his inflammatory markers reduced as shown. The vasopressor support was reduced by 3. He was off dialysis by day 7. There were gangrene of fingers and toes secondary to thrombotic microangiopathy, which required ultimately after about 2 months or so, he had to undergo amputation of his uh, fingers on the left side as well as both legs, distal legs. Fortunately, his right hand, which is functional, was spared and did not have to undergo any amputation there. And he improved gradually and was discharged by 45th day from the hospital. So this is one type of stroke which we see, wherein you have serious COVID associated with stroke. And here, of course, nobody doubts that there is a relationship of COVID pathology and whatever immune response to the stroke itself. And this is one, incidentally, a paper which said that decompressive hemicraniotomy can be done in acute stroke. This just to highlight that even in COVID era, one can manage and follow all the stroke protocols and give good outcome. What about stroke and COVID? And this is the study which was done, which showed that approximately 1.5% of patients with emergency department visits for hospitalization for COVID experience ischemic stroke. And this rate is almost 7.5 fold higher than the patients with influenza. So obviously, COVID has probably, at least epidemiological data would support that stroke does occur more commonly with COVID pandemic and in relation to COVID than influenza. And why do we that occur? So this is the why do we feel that there is a relationship, and that this is occurs from observations from various publications, that in the COVID the New York report showed that there's an increased proportion of large artery occlusions. Then sometimes you are seeing infarctions involving multiple territories, and despite detailed investigations, many of those people have cryptogenic stroke. So, in view of these three factors, it appears that there may be some causal relationship of COVID infection or COVID viral infection to the stroke. But sometimes, of course, there is a coincidence, which we're going to discuss as we go further. So, what are the proposed mechanisms which I already highlight? There's three proposed mechanism is cytokine storm and activation of innate immune system. There may be embolic phenomena because of associated cardiomyopathy and arrhythmias. Hypoxemic induced is ischemia because of the severe pulmonary disease. Thrombotic microangiopathy, basically related to endotheliopathy or endotheliitis, as we call it. And endotheliitis itself may lead to activation of coagulation cascade because from tissue, and there is probably inhibition of fibrinolytic system and tissue factor pathways. So the hypothesis that COVID-19 contributes to stroke risk differently depends on the severity of illness. The case which which I showed suggests that there was a relation because he had severe COVID and there was a relationship. But you would probably see many patients where there is a coincidence of stroke and COVID. And so, I mean, the incidence of 7%, 5.7% in severe cases versus only 0.8% in milder cases suggests that there is a relationship in severe cases. One is likely to have stroke, which is probably COVID related. So, how does SARS-CoV-2 infection lead to thrombotic tendency? And there are various, as shown in this probably schematic drawing. You would say that there is probably dysregulation of RAS system, renin-angiotensin system is dysregulated. There is hyperinflammation, platelet activation, neutrophil extra trap formation, which will ultimately lead to thrombin formation, changes in coagulation system, myocarditis, and probably vascular injury, and of course endotheliasis. So all these probably contributes to probably stroke and microangiopathy, thrombotic tendency in patients with COVID infection. And so this just summarizes that probably 24% have pulmonary embolism in various series, 20% have myocardial injury, deep vein thrombosis in about 46%, stroke in 1.6%, and in stroke you have all the categories. You have venous thrombosis, cerebral venous thrombosis, intracerebral hemorrhage, and of course ischemic stroke. All three are well described, and the point various mechanisms which are been shown in the previous figure are already mentioned again here. So, what are the factors involved in stroke? Just to summarize, coagulopathy, inflammation, elevated D dimer levels, elevated fibrinogen levels, DIC, sepsis. In some patients, there is a lupus anticoagulant has been positive. In our series, we did not find lupus anticoagulant positive in any of cytokine storm, endothelial inflammation, and immune thrombosis. This is the RFH data. This our hospital showed that when we looked at our statistics in March, April, as you say, there was a lockdown in 2020. Then we had less number of stroke patients. From May, also probably it was less, and from June onwards, we saw more number of stroke patients than the previous year, and that continues despite the fact that COVID graph is coming down. We continue to see more number of stroke patients in October and November as well. So this means that probably there is no direct relationship of stroke to COVID as far as our statistics is concerned. Now, out of all these patients, this is I'm talking about total stroke patients. Out of all these, which were ischemic stroke, so we probably saw about 20 patients related to COVID, and this is the slide. We have 18 ischemic stroke patients and 2 intracerebral hemorrhages. Age range from 30 to 88 years. The onset to presentation time was mainly from 1 to 12 hours, and only 2 patients at one at 24 and one at 72 hours. NIHs varied from mild strokes to severe, so varied from 4 to 19. The large vessel occlusion was present in almost 6 out of 18, that is 33% of patients. Deep cerebral infarction was present in 6. And we could do intervention, that is IV RTP in 1 patient, and endovascular therapy in 4 out of 18, and most of them in late window. So they were all probably arrived late, but they were right candidate because of the study showed that they were in still having penumbra, and that's why they were given benefit and with good success. This is interesting that COVID symptoms and positive CT chest was present only in 8 out of 18 patients. And most of the mortality in relation to COVID stroke goes into range of 30%, but our mortality is only 16%. And as we mentioned, there are NIH was 0 to 4 in 10 patients. So we had mild strokes, not all of them they were bad severe strokes, and severe strokes are probably also there between 5 and 8. So this is one example of a patient, again, probably COVID-related stroke, we can say here, because it's cryptogenic. She's a 51-year-old lady with no risk factors, and she presented with left MCA infarcts, but when we investigated, her MRI also showed there is another additional lesion in the cerebellum and cerebral peduncle, which means she had 2 different territory strokes. And when we did angio, she had, of course, large vessel occlusion. M1 was occluded, and that was probably responsible for this. But as you can see, even though she came in late window, she was in penumbra because the M1 was occluded, but the damage was only limited to subcortical tissue. So she was taken up for endovascular therapy, mechanical thrombectomy, a clot was removed, and the artery became intact, and this final infarct was only limited to this much. So she did very well, and her recovery was excellent. So this was obviously COVID-related stroke, possibly because it's a cryptogenic, embolic, multiple territory, probably. But as opposed to this example, like a 70-year-old man with probably risk factors, his CT had already showed changes of COVID. She had a left MCA stroke, and when he did again left MCA M1 segment occlusion was demonstrated. So when he underwent angiogram, he showed that there was a pre-existing disease of the neck carotid artery ICA in the neck, and that was possibly responsible for the thrombus going around, which was removed, and its MCA was recanalized, and probably because this was again the required angioplasty of this vessel, and ultimately stent was done. So here, even though he had COVID symptoms and probably COVID pneumonia also, probably his stroke was not related to COVID, and is probably there was just coincidence, and stroke was possibly related to ICA disease, which was there pre-existent in him. And this is one more example where we just mentioned that even in presence of COVID, one could do decompressive craniotomy with good result. This is a 51-year-old man who had cerebral infarction and probably right vertebral artery occlusion. You can see an infarct there. And within 24 hours or so, the edema worsened, he developed hydrocephalus, and he underwent decompressive craniotomy, and probably his outcome was good, and he improved discharge, could walk unassisted. So now coming back to the literature, now this is what the first paper, which was from the New York, which says that emergent large vessel occlusion was much more common in the COVID pandemic period, that is March 21st April to 12th April. This is probably 3 weeks period. They saw maximum number of large vessel occlusions in New York City in the particular hospital, and out of this 50% of them were COVID positive, and that probably led to this paper, which is large vessel occlusion strokes occur in New York City at younger age. Now, this was possibly proven that then more than half of them were COVID positive in their series. And then they also showed that prognosis of patients with stroke, this is probably the controls where probably non-COVID stroke patients, this is how the statistic is. Outcome is that modified Rankin score, this is probably death, and this is a severe outcome. So if you see here, patient with COVID, the almost 30% was the mortality, as compared to normal mortality of only about 12 to 16%. So this is what they compared in a global COVID-19 stroke registry publication, which is just done in 3 months ago. As opposed to that, we have other papers. Now, in New England Journal, probably the 25 hospitals, they studied there. So they come to conclusion they did not find any replicate the previously reported findings. They did not find young patients with LVA stroke, and probably they said there is nothing like this, which probably what New York observed. And from the New York also, the other center from New York probably also did a prospective study, multi-center cross-sectional study they did, and they also found that there was probably stroke occurred less frequently in these COVID patients that they could not replicate. So I think the story remains unclear as to really is a large incidence of stroke in COVID or not. So severe COVID, in my opinion, probably severe COVID does lead to thrombotic complications, but it's not as common as we think. And of course, statistics will probably say 1 to 6% probably is correct. The management issues in patients with acute stroke in COVID are these are the management issues. Can we use IV RTPA or not? In our series, we use RTPA in only one patient, and that patient, of course, did not have evidence of all systemic inflammatory syndrome, and probably he did not have hepatic. So, if you suspect that he person has signs of systemic inflammatory syndrome and probably innate immunity is already affected and the liver is affected, then probably RTPA use will lead to higher chances of intracranial hemorrhage. So that's the only caveat. So that's why your door to needle time in patients with COVID will be extended, because you will have to confirm COVID and you will have to wait for coagulation parameters, liver function test, and then decide whether one could use it or not. What about anticoagulation? That's probably indicated in loss of low molecular heparin, and Novak is indicated. And how long to give is debatable. Up to 6 weeks, people say, but you can go up to 3 months depending on the severity of the COVID infection. And role of antiplatelet is debatable, but I think, as we mentioned in this graph, that the platelet activation does occur, and probably thromboprophylaxis has some role in these patients as well. So I would take this opportunity to just review. There is the infection apart from COVID, other infections also as a risk factor for core. I think yes. If you go through the history, historically, varicella zoster virus, tuberculosis, syphilis, all of them have been linked to this influenza. All of them lead to has some issue in precipitating a event of stroke. And this is the various postulations that endotheliopathy is not a new. It was described with varicella zoster as also parvovirus also was described. Similarly, acceleration of atherosclerosis is postulated with chlamydia pneumonia infection, or people with periodontal infection can also lead to early atherosclerotic process, and influenza and all that can cause platelet activation, dehydration, and can induce so infection and stroke is not a new phenomenon. It has been described even in past, and it's just that the COVID has increased our incidence again. And so there are various bacterial infections which can cause stroke, which we already just mentioned, and probably we'll just run through this. Only virus I'll be interested in. So we just mentioned varicella zoster is known to cause arteritis of the carotid artery and stroke, which is well described. Influenza virus, as we mentioned already, and SARS-CoV-2 has various things which we discussed. So infection is one of the risk factors for stroke, or trigger for stroke is well known. So in coming back to stroke management, I think again protected core stroke, which we were following, is recommended, because as we just mentioned that some of the people who develop stroke may not have respiratory symptoms of COVID, and that's why when you suspect, you probably as a screening procedure, we follow the same pathway and which should be followed. That people who are examining and people a consultant may not go all the way down to see the patients, but somebody is examining probably through video consultation who could probably decide whether he has a stroke or not, understand his NIH score, so interpret his probably and follow up. And that's how we managed our stroke during COVID pandemic. What about other vascular complications? Intracerebral hemorrhage is described. This is a young man, 42, who had no risk factors. He came with massive intracerebral hemorrhage. We probably did not have COVID positive, but his RT-PCR came positive, and within hours his bleeding increased and probably with loads. So literature also is full of case reports where intracerebral hemorrhage can occur. The direct relationship is not probably understood well, but probably some sort of endothelial toxicity may be involved in probably precipitating COVID-related intracerebral hemorrhage. The other thing which we observed is a man who had COVID infection, and his MRI showed changes of PRES, posterior reversible encephalopathy, as shown here. And he had inhalation pancreatitis and hypercalcemia. Now, hypercalcemia itself is also known to cause PRES. So we were not sure in this man whether the PRES was related to COVID or hypercalcemia. But when we search literature, the PRES has been described in patients with COVID infection, and on even in postmortem studies, this found that brain MRI demonstrates hemorrhagic PRES-related brain lesions in non-survivors of COVID-19. So PRES is another vascular complication one can see in COVID infection. So these are the vascular complications. Moving away from vascular complication, I thought we'll just mention some case of interesting problem of Guillain-Barré syndrome, which is described, as I mentioned, Miller-Fisher variant and autonomic neuropathies both are described. What we saw in this gentleman, he is a 69-year-old man who came with imbalance of walking, slurring of speech, and had holocranial headache. Neurological examination was not normal on day of admission, except for dysarthria, and was unable to walk. His balance was there. When we did his MRI, we picked up say changes of limbic encephalitis. Abnormal diffusion showed abnormalities in the hippocampus and the medial temporal region. So these changes were typical of a possibility of herpes simplex encephalitis. So at this stage, his COVID was negative. He did not have CD thorax of COVID signs. So we thought that he's probably HSV1 infection, and which was confirmed by CSF examination. And he was treated. He was started treatment for this. Of course, subsequently in next 24 hours, he went into status epilepticus, which was treated properly with the EEG monitoring. But when he midazolam was stopped, at that time he started having fever spikes, and his RT-PCR was repeated, and second time turned out to be positive. So he had HSV encephalitis, limping encephalitis. Now he turned out to have COVID, and then what the examination on day 6 showed that he was totally quadriplegic with areflexia. So this was very difficult to understand. Looking at the brain MRI, which had shown only limbic encephalitis and no other changes to explain why he was quadriplegic and probably areflexic, which was, we thought there was some additional lower motor neuron problem going on. Because he became COVID positive, he was probably sent to COVID facility where he underwent tracheostomy, ventilatory care, and until about 14 days period, he stabilized and became COVID negative. He was transferred back to our facility where in this time we did now conduction studies which confirmed demyelinating polyradiculopathy. He was given intravenous immunoglobulin thinking that it is probably Guillain-Barré, and probably he recovered well. So these are these charges. Limbic encephalitis, vessels were normal. CT again showing same changes. CT thorax later on showed some changes of COVID pneumonia, and his second CSF showed raise in proteins, typical features of Guillain-Barré syndrome, which was again confirmed by electrophysiology. So the interesting combination of factors we had in this patient. So in summary, as many as 13 to 33% of patients have SARS-CoV-2 infection may have neurological infection. We will all anosmia and loss of taste and fever should have a strong suspicion. Patient present with acute stroke may have associated COVID-19 infection without over systemic or respiratory symptoms and hence need for protected stroke code, which I have emphasized. And stroke associated SARS-CoV infection are more severe, but outcome can be improved with following standard stroke protocol. So it is what I was showing is from our RFH data that it is possible to follow standard stroke protocol and good proper results. New onset unexplained seizures could be presentation of COVID-19 infection during pandemic, which we saw in many cases. And COVID-19 infection in an elderly may present with acute confusional state and change in behavior with or without fever. And finally, post-COVID syndrome like myalgia, fatigue, shortness of breath, and of course, anybody who was post-COVID may come with mononeuropathy or come with the Guillain-Barré syndrome, and to be kept in mind. Thank you.
So we now move forward. We now move forward and go on the topic of vasospasm in traumatic brain injury. Dr. Darshana Rathod will present a case and the discussion will be done by Dr. Vishank Shah. Dr. Darshana is a consultant in critical care at RFH Hospital, has worked in various other hospitals previously before joining here, has extensive experience in medical emergencies, medical intensive care and surgical intensive care, and currently her interest is in chronic critical illness and quality in critical care. She'll first present the case and then Dr. Vishank Shah will be talking about refractory vasospasm and vasospasm in traumatic brain injury. Dr. Vishank Shah is Assistant Professor of Neurology and Neurosurgery, Director of Neurocritical Care, Co-Chair of Neurocritical Care Safety Committee at University of Arkansas Medical Sciences. He's a Bombay boy from KEM and said GS Medical College, did his neurology from Baylor College of Medicine, Houston, and then did his neurocritical care at Johns Hopkins University School of Medicine at Baltimore, Maryland. He has numerous publications, presentations, several papers, and is actively involved in educational activities and research projects. Last year, he was at RFH as an invited speaker for the same conference. And in June 2018, was received the Academic Achievement Award and Resident Teacher Award at the Baylor College of Medicine. So over to you, Darshana, without wasting any time.
Thank you, sir. Thank you, Dr. Arun Shah, for giving us the opportunity for this conference, as always. I would just, in short, present a very short case, and then Dr. Vishank would go ahead with the topic that which I will highlight in this presentation. So we had a patient who was a 41-year-old female, and she was transferred at our hospital from another hospital, which was a private hospital. And she didn't have any comorbidity. She was brought to RFH here on 14th of November midnight. She had a road traffic accident on 13th of November around midnight 12:30. She fell from the bike and hit her head on the back. And post event, she developed unconsciousness. She had seizures and bleeding from right ear. She was taken to a private hospital where she was intubated in view of low GS with the GCS, which was around 5/15. She was put on ventilator, and then we received her on the next day, which was exactly after 24 hours. The CT brain, which was done over there, was already showing hemorrhagic contusion in the left temporal region. The basal cisterns had effaced and with mild SH in left sylvian region. So here, this was a young lady with no comorbidities, just had a RTA and had come to us. We knew that this patient may not make it, but with the basal cisterns which were effaced, some kind of hope was there. And Dr. Vivek Agarwal himself had taken up this patient for surgery. Relatives were told that she may not make it as we wish, but still we can give a try. She underwent a left-sided decompressive craniectomy and hematoma evacuation on the very immediate day that she came. Post-op, she was shifted to the ICU and she was continued on mechanical ventilation, anti-epileptics. After stabilization and stopping the sedation, her GCS gradually improved to around 7/15. From day 5 to day 10 of the traumatic brain injury, we noticed that she was showing few improvements in her day-to-day when we used to examine her in the GCS, as well as we were able to wean her off the ventilator very easily. But we knew that this is a patient who is going to take a long stay and will not be able to protect the airway. So we had done a tracheostomy followed by a PEG tube, and we weaned her off the ventilator to TPs on 21st of November. The CT brain, which was done on 18th, revealed basal cisterns which had opened up. So we thought that, okay, we can just continue with the care and try to see how more she recovers. Unfortunately, from day 12 of the brain injury, she started developing autonomic dysfunction and we could not really make out what was there. And as you know, in such kind of patients who are intubated outside, they can also come with some kind of infection. We were trying to rule out the infections for the fevers, for the tachycardias and all. But there was a very drastic autonomic dysfunction, as well as there was a drop in the GCS, which came back down to 5. So we thought of going ahead for an imaging. And at this point of time, we thought that might as well do a angiography with the imaging. And what we noticed was that there was a non-hemorrhagic completed infarct in bilateral MCA territories, left more than right, as well as there was bilateral vasospasm of both MCA with both frontoparietal infarcts, which was all secondary to post-traumatic vasospasm. And this is the images that you can see, and you can see the vasospasm, which I've already marked over there. This patient, we offered to do a DSA with chemical and chemoangioplasty. Unfortunately, by then, the family had decided not to go ahead with any aggressive measures of treatment, and therefore it was not done. Without wasting any time, I would just ask Vishank to go ahead with the presentation, which will be a continuity to this case. Thank you.
Okay, yeah. Yeah. Can you see the presentation?
Vishank, we can see the presentation. Just put on slideshow.
Hello?
We can hear you also, and we can see the presentation. Yeah.
Okay, all right.
Yeah.
Okay, perfect. All right, thank you. Hello, everyone. So I'm Vishank Shah. I was just going to talk to you about cerebral vasospasm with specific focus on refractory vasospasm and post-traumatic vasospasm, which is less commonly talked about. I have no disclosures. The objectives of my talk are to go over definitions of vasospasm and delayed cerebral ischemia and how they are different, review pathophysiological mechanisms of vasospasm, and then go over monitoring, management, and then specifically talk about vasospasm in traumatic brain injury or post-traumatic vasospasm. As we all know, cerebral vasospasm is simply just delayed narrowing of the large arteries within the basal cisterns. And there are two types that are described, angiographic and then symptomatic vasospasm. Angiographic spasm is fairly common, particularly in people with aneurysm with subarachnoid hemorrhage, which is where it's most commonly described and studied. And almost 50 to 70% of patients with subarachnoid hemorrhage will have vasospasm on vessel imaging. But when it is associated with new neurological deficits, we call it symptomatic vasospasm, which is seen in about 30% of patients. Delayed cerebral ischemia is a newer terminology that has been brought into discussion. And we'll talk about why it's important to distinguish that from vasospasm. But delayed cerebral ischemia is a broader term that describes global or focal neurological deterioration for more than 1 hour, and or radiographic evidence of a new stroke that cannot be explained by any other neurologic or systemic condition. So is cerebral vasospasm the same as delayed cerebral ischemia? And so this is important to understand because not all patients with delayed cerebral ischemia actually have vasospasm on imaging. And like we discussed earlier, not all patients that have angiographic vasospasm actually have signs and symptoms of delayed cerebral ischemia. And this has been confirmed time and again with various studies as well. So nimodipine, which we know we commonly use in subarachnoid hemorrhage, it is known to prevent delayed cerebral ischemia and improve outcomes, but it doesn't really improve vasospasm. And a lot of times we see signs and symptoms of delayed cerebral ischemia that do not correspond to vascular territory. And so what we learn from all of this is that delayed cerebral ischemia is a much larger phenomenon that is caused by various different factors. And of course, in addition to the most commonly understood mechanism where there's blood in the subarachnoid space, which releases inflammatory mediators and endothelin 1 and causes vasospasm, in addition to microthrombosis, microvascular vasospasm, one of the newer concepts is the role of cortical spreading depolarizations or depressions. So when the aneurysm ruptures, there is an event called early brain injury, which occurs because of an acute rise in the ICP and reduction in cerebral blood flow leading to transient global cerebral ischemia, which tends to trigger the formation of cortical spreading depolarizations. And so these are just, these have been extensively studied in migraine, but are becoming of interest in subarachnoid hemorrhage and now also in traumatic brain injury. So they're basically just slowly propagating waves of depolarization that spread from one part of the cortex to the entire cortex. And while they spread, they cause disruption of the ion homeostasis and release of excitatory neurotransmitters like glutamate, and end up causing sustained reduction in cerebral blood flow for a prolonged period of time, leading to ischemia. And so this was a paper that first described this phenomenon in patients with subarachnoid hemorrhage. So you can see these were cortical electro EEG leads that were placed in the frontal lobes. And so you can see channel A, B, C, D, all of them are have the same type of activity while the patient is awake, alert, and oriented. And then suddenly the patient becomes stuporous and aphasic, and you see these slow, large, high amplitude waves that start propagating in channels C and D associated with decrease in activity. And so this has been shown to be important. And this is important because we'll talk about it in the future slides, but there is a role for medications that can suppress cortical spreading depolarizations in treating vasospasm and delayed cerebral ischemia. So in non-traumatic vasospasm or vasospasm associated with aneurysmal subarachnoid hemorrhage, the major risk factors are listed in this slide. But the most important of these is obviously, as we all know, the amount of blood on the CT. So based on this, there was a Fisher scale that was created that looks at, that basically grades the amount of blood. So grade 1 is thin SAH all the way to grade 4, which is thick SAH and IVH. And when they looked at the risk of developing vasospasm, the higher the Fisher grade, there was a higher odds for developing vasospasm. And so this is the most important risk factor. In addition to poor clinical grade, loss of consciousness at onset, history of smoking and cocaine use, SIRS, non-convulsive seizures, and hyperglycemia. So coming to prevention and monitoring of vasospasm, So the preventative strategies for vasospasm or delayed cerebral ischemia include nimodipine, lumbar drainage, maintaining euvolemia and prevention of hypovolemia, and then maybe some newer therapies that I'll talk about. So nimodipine, we all know, is the standard of care for aneurysmal subarachnoid hemorrhage, and it's the only medication that has class 1 evidence for use. And it blocker, which is lipophilic and crosses the blood-brain barrier, and that's why it's the preferred calcium channel blocker in subarachnoid hemorrhage. But the important thing to remember is that it actually, in the original studies, did not reduce the incidence of angiographic vasospasm. However, it did decrease the risk of poor functional outcome and DCI-related cerebral infarction, and that's why it is used. We still don't understand exactly what the mechanism is, although there are a lot of different theories. So like one of the things we mentioned, microvascular vasospasm is prevented by nimodipine, which we may not be able to see on angiograms. Also, it may reduce microthrombi and then calcium-mediated excitotoxicity, and there may be some role in reducing cortical spreading depolarizations as well. Lumbar drainage, this is based on the concept that more blood in the subarachnoid space is associated with higher incidence of vasospasm. So if there is so with gravity, most of the blood actually sits in the thecal sac. And so the idea is to place a lumbar drain early and drain as much blood as possible to reduce the incidence of vasospasm. There is good retrospective evidence, but not strong prospective evidence for its use. But in retrospective studies, it has been shown to reduce clinical vasospasm as well as improve the likelihood of functional independence. And so the guidelines recommend using it in people who are higher Fisher grade, so who have more blood on CT grade 3 and grade 4. And we use it very regularly in the University of Arkansas. Maintaining euvolemia. So this is the other important strategy. So there are extensive studies that have shown that hypovolemia and dehydration are associated with increased risk of vasospasm and delayed cerebral ischemia, and also can exacerbate symptoms of vasospasm when the circulating blood volume is low. And so there is class 1 evidence to maintain euvolemia. In the olden days, we did do prophylactic hypervolemia. So people would, if they came with subarachnoid hemorrhage, you would start them on 100, 150 cc's per hour of IV fluids. And that has been questioned. There are actually newer studies that have shown that if people have a positive fluid balance in the first 72 hours, they have worse outcomes with subarachnoid hemorrhage. And so at this point, there are no recommendations to do prophylactic hypervolemia, only maintaining euvolemia. Then the newer therapy that was just recently published about 3 or 4 days ago is cilostazol. So cilostazol has shown to reduce cortical spreading depolarizations in previous studies, and a recent meta-analysis that looked at different trials that evaluated cilostazol actually showed that there was reduced odds for symptomatic vasospasm as well as infarcts in people with subarachnoid hemorrhage. So this might be something to watch for in the future in preventing vasospasm in people with subarachnoid hemorrhage. So the next part, in addition to preventative strategies, is monitoring for vasospasm. And the goal of monitoring is to catch it before it leads to permanent infarction and permanent disability. And so the current guidelines recommend that all patients who are at high risk for vasospasm should be monitored in an ICU setting for the entire vasospasm period, which is between day 3 to day 14 after subarachnoid hemorrhage, preferably in a neuro ICU if available, with frequent neurological checks. In addition to neurochecks, which is currently the best marker we have for vasospasm, there may be other non-invasive methods of monitoring as well, like transcranial Dopplers and quantitative EEG. These will become more important if the patient has a poor neurological exam to follow. So transcranial Dopplers are the most commonly used non-invasive monitoring modality. We use it on every subarachnoid hemorrhage patient from day 3 all the way to day 14. We just do them every day, and we look at the velocity in the middle cerebral artery and the ICA, as well as in the posterior circulation. There is good correlation with vasospasm, particularly in the anterior circulation. If the velocities are more than 120, we call it vasospasm, and then you can grade it as mild, moderate, and severe. EEG monitoring can also be used, and this is based on the principle that as the cerebral blood flow decreases, the fast EEG waves are replaced by slower waves. So alpha activity, which we see in normal awake patients, gets gradually replaced by delta activity. And so quantitative EEG monitoring is where there is a software that uses a technology called fast Fourier transformation and converts and calculates the power of alpha versus delta activity and generates a ratio in each hemisphere. And then you can follow the trends of that alpha delta ratio. And if there is a drop in the alpha delta ratio, is particularly asymmetric, can suggest ischemia in the right clinical setting. And so this is an example for that. So you can see in this patient, if you look at TAP 4, which is the alpha delta ratio, initially there is both the left and the right side are basically following the same trends. And then there is a sudden drop in the left-sided alpha delta ratio with a separation between the two waveforms. And this patient ended up having a left MCA stroke. So this is one of the ways in which you can also detect vasospasm using quantitative EEG. So coming to management of vasospasm, so if you just have vasospasm by transcranial Dopplers or angiogram, but patient has no deficits, then the management is just watchful. We just do more closer neuromonitoring. We may raise the lower blood pressure limits. So, we make sure that the patient doesn't drop their pressure below 120 or 140 based on what their blood pressure is running at that time. And then also maintain euvolemia aggressively. And sometimes this is a problem in people with subarachnoid hemorrhage who also get salt wasting. And so in some situations, we do one-to-one fluid replacement where every hour you replace their urine output with IV fluids to make sure that they're maintained. You maintain euvolemia, or you can also do dynamic hemodynamic monitoring, which is even more accurate way of assessing volume status. So, but once the patient gets symptoms, then we follow this protocol. So if the patient is hypovolemic, then you can start with a fluid bolus. If the patient is euvolemic or the fluid bolus doesn't help, then the next step is to induce hypertension with vasopressors in a stepwise manner. You can also consider inotropes to augment the cardiac output. And if despite all of this, the patient's neurologic exam doesn't improve, then we move forward with more invasive treatments for medically refractory vasospasm. So triple H therapy for vasospasm was something that used to be done in the past. It's a combination of hypertension, hemodilution, and hypervolemia. But in several studies that looked at cerebral blood flow comparing vasopressors, inotropes, and hypervolemia, you can see that hypervolemia did not really have any improvement in the cerebral blood flow, and is also been shown to associated with higher complications, so higher incidence of pulmonary edema, hyponatremia, and myocardial ischemia. And so at this point, triple H therapy is outdated. We do not recommend hypervolemia, and it has been replaced by euvolemia and induced hypertension. So if the patient is euvolemic, there's no role to give additional fluids, and you can just move to induced hypertension with vasopressors. And so this is based on the principle that in people with subarachnoid hemorrhage, and then there is a loss of cerebral autoregulation, and the cerebral blood flow becomes directly proportional to the mean arterial pressure. So if you raise the map with pressors, the cerebral blood flow will increase in a linear fashion. And retrospective data shows that it reduces odds for poor outcome, and then also may reverse neurological deficits in up to 2/3 of patients. And so usually the consensus goal and guidelines by the Neurocritical Care Society, as well as the American Heart Association, is to raise the mean arterial pressure by 20 points and then reassess the patient's exam. And you can go all the way up to a MAP of 140 and a systolic of 240 if needed, as long as the patient is tolerating, and of course the aneurysm and source of bleeding have been secured. In terms of choice of vasopressors, norepinephrine and phenylephrine maybe are both okay, but there are some studies that have actually compared the two and showed that there is more complete response with norepinephrine and higher likelihood of being discharged home or rehab in people with norepinephrine compared to phenylephrine. So norepinephrine may be preferable. In terms of inotropes, so this is, again, not a very common practice, but there are studies that have shown that inotropes actually also increase cerebral blood flow by up to 45% when compared to vasopressors and have equal efficacy. So you could also consider, instead of doing induced hypertension, using inotropes and augmenting the cardiac output or cardiac index. But usually you use that in conjunction with cardiac output monitoring. The most common scenario in which we would use this is if somebody with subarachnoid hemorrhage also has heart failure or neurogenic stress cardiomyopathy or Takotsubo cardiomyopathy. Then, adding inotropes and vasopressors together may be helpful. So milrinone is becoming more and more commonly used in this scenario. And this is because in addition to cardiac output augmentation, milrinone actually has intracranial vasodilatory effect because it inhibits the phosphodiesterase 3 receptors in the intracranial vessels. And so it is being considered more commonly. And there's actually a Montreal Neurological Hospital protocol that was developed, as that's shown on the right here. So if a patient develops signs and symptoms of vasospasm, in addition to correcting hypovolemia, you can start IV milrinone, usually a 0.1 to 0.2 mg per kg bolus, and then start an infusion at 0.75. And then if they're hypotensive, then add norepinephrine to maintain the MAP. And then you can reassess in 30 minutes. If the patient's exam is not improving, you can keep increasing the milrinone and the norepi to maintain the MAP and cardiac output. And if the patient continues to have a poor exam, then go for intra-arterial therapy with milrinone. And then usually they continued this IV milrinone infusion for a median duration of about 10 days. And all the patients had a good outcome. Of course, it was not a prospective, it was not a randomized control trial, so there was no control arm. But we see a significant benefit with using milrinone in clinical practice as well. So if the patient doesn't respond to induced hypertension and cardiac output augmentation, we call it medically refractory cerebral vasospasm. And in this situation, the next step is DSA with intraarterial vasodilators. Angioplasties, you may use intraventricular nicardipine. So intraarterial vasodilator therapy is again used very commonly. Again, there are no randomized control trials, but this is preferable if you have diffuse vasospasm in distal second caliber vessels. The most commonly used vasodilators include verapamil, nicardipine, and milrinone. Particularly if you're using IV milrinone, it's preferred to just use IV milrinone in those patients. There is really no significant difference from one agent or the other. The main issue is that the impact of this is often short-lived, and these patients may need serial angiograms with IA therapy if they're in refractory vasospasm. Angioplasty can also be used, but this is mainly used for large caliber vessels and vessels, proximal vessels, like the MCA or ICA. And there is a chance of obviously causing vessel rupture, dissection, and thrombosis. And so it should not be used for smaller distal vessels. So intraventricular nicardipine therapy is, again, not studied prospectively in any trials, but there's a lot of case series and of its successful use. And so the situation in which we have used it previously is if the patient has ARDS and other medical issues that makes them unstable for transport to the IR suite. So in those situations, we would just start intraventricular nicardipine and see if that improves the patient's clinical symptoms or TCDs. So usually you give 4 milligrams of nicardipine and flush it with preservative-free saline every 8 to 12 hours through an EVD. And it has been shown to improve TCD velocities as well as clinical vasospasm. And there was a recent paper that showed that it reduces the need for repeated intra-arterial therapies by DSA. We still don't know how this impacts outcomes, and this is something that people are getting interested in, and there may be a trial in the future. So finally, this brings us to post-traumatic vasospasm, and Dr. Darshana presented an excellent case that demonstrates this scenario. Although it's rare, it is a condition that we need to be thinking of more often in people with trauma. So the incidence of post-traumatic vasospasm is very variable in depending on what studies you look at, and it's not been studied extensively. But overall, if among all TBI patients, it can be seen in up to 5 to 20%. And in severe TBI, it's more common, and up to 30 to 40% of the patients may have a vasospasm. So that's pretty high. But clinical and symptomatic vasospasm can be anywhere between 7 to 17% of patients with severe TBI. The main risk factors for TBI from the demographic standpoint is young age. So the younger patients, particularly less than 30 years of age, are at very high risk of getting vasospasm. And it can also be seen more commonly in males, but we don't know if this is mainly because there's a higher incidence of trauma in males. The mechanism of injury, any type of injury mechanism can lead to post-traumatic vasospasm, but particularly what is important is blast injury in wartime combat patients, as well as gunshot wound and penetrating head injuries are associated with higher incidence of vasospasm. So severity of injury is the single most important risk factor. And so there is a strong link with the admission GCS. So the admission GCS is less than 9, those people are at higher risk of developing post-traumatic vasospasm, and lower the GCS, higher the risk. In addition to clinical severity, imaging severity can also be associated with a higher risk of vasospasm. So based on their Rotterdam CT score, which is a score to grade the severity of TBI, the higher the CT score, the higher the incidence of vasospasm. The specific imaging findings that are linked to post-traumatic vasospasm, so obviously traumatic subarachnoid hemorrhage is the most important risk factor. So it's for almost 40 to 50% of the patients with traumatic subarachnoid hemorrhage, particularly if it is in the basal cisterns, that are high risk of vasospasm. Intraventricular hemorrhage, subdural hematoma, small intraparenchymal contusions, and then in blast injury, multilobar blast injury is also associated with higher risk of vasospasm. Importantly, epidural hematoma and then people who have diffuse edema from diffuse axonal injury do not typically get vasospasm in whatever literature has described this. So in terms of onset and duration, there are 2 types of post-traumatic vasospasm that have been defined. So this is a little bit different from aneurysmal subarachnoid hemorrhage. There's early vasospasm and late vasospasm. Early vasospasm usually begins within 24 hours of the trauma and resolves by day 5. It can be seen in any form of trauma, and it's not specific to traumatic subarachnoid hemorrhage, and has been linked with higher mortality in people with trauma. Late vasospasm is more classic, like the vasospasm we see with aneurysmal subarachnoid hemorrhage. In fact, pathological studies have shown similar changes in the vessel wall as you see with aneurysmal SAH, and it's more commonly seen with people who have traumatic subarachnoid hemorrhage. The main distinction between delayed vasospasm from traumatic SAH, aneurysmal vasospasm, is that even earlier as compared to what you see with aneurysmal SAH. And then it is overall less common. So you can see it in up to 40% of people with aneurysmal SAH, but in trauma, it's only about 4 to 15%. And we really don't know if this does cause long-term ischemic injury. Whereas in aneurysmal SAH, ischemic injury can be seen in up to 30%. In traumatic SAH, this is controversial, and some studies have shown variable incidence from 7 to 18%. So what is the clinical significance of PTV? We don't really talk about this phenomenon in trauma, and a lot of times we are taught that vasospasm doesn't occur in people with trauma, and even if it occurs, it doesn't have that much significance. And from reading the literature, it sounds like most of the reason I don't consider this important is because it is just not studied very well. And there were some studies that actually showed that when you have hemodynamically significant vasospasm, so they compared the TCD velocities with cerebral blood flow, and when the TCD velocities were high with a reduction in cerebral blood flow, those patients actually had much higher odds for poor outcome than people who didn't have vasospasm. So it does impact outcomes in TBI. But I think the problem is there are so many other confounding factors, and the patients usually already have a really poor neurologic exam at baseline. And so we don't really understand how much this impacts, but there is definitely a role of vasospasm impacting long-term outcomes in people with TBI. So treatment specifics for post-traumatic vasospasm, so nimodipine. Unlike in aneurysmal subarachnoid hemorrhage, nimodipine actually did not reduce odds for death or severe disability in people with TBI. In multiple studies that were done, and then also in this large Cochrane meta-analysis. When they only looked at people with traumatic subarachnoid hemorrhage, nimodipine again did not really have any impact on disability or death. And so there's really no role for using nimodipine in traumatic subarachnoid hemorrhage, even though there is a higher incidence of vasospasm. And actually, nimodipine may be detrimental in TBI. So all the studies showed a higher incidence of hypotension with the use of nimodipine, which would be expected given that it's a calcium channel blocker. But hypotension in TBI is harmful. We know that there is a linear correlation with number of hypotension episodes and mortality after TBI. And so given that it doesn't have any benefit and it can cause hypotension, which can worsen outcomes, nimodipine has no role in trauma. Hemodynamic and volume augmentation. So this can be considered, but again, it is problematic in people with TBI because unlike in aneurysmal subarachnoid hemorrhage, where you can secure the aneurysm, the source of hemorrhage and trauma is unsecured. And so if raising the blood pressure, to 240 can increase the risk of rebleeding. There's also been shown to have a higher incidence of cerebral edema with hemodynamic and volume augmentation, higher risk of ARDS and systemic hemorrhage if you have polytrauma. And so you may not have the freedom of just raising the blood pressure significantly in people with post-traumatic vasospasm. So really the mainstay in post-traumatic vasospasm is endovascular therapy. Again, there are no class 1, class 2, or class 3 studies for traumatic vasospasm as such because it's just not well studied, but there are several case reports and case series that have shown intra-arterial calcium channel blockers being used with success in people with traumatic vasospasm. Milrinone, again, has not been studied extensively. There was just one case series that documented successful use, but there doesn't seem to be a lot of harm in using IA milrinone or IV milrinone, given that it doesn't really cause hypertension. And so it can be something that to consider in people with post-traumatic vasospasm. So to conclude, vasospasm is a complex phenomenon and only part of the problem that contributes to delayed ischemia after brain injury. It can occur in people with TBI, contrary to what we believe, and it can be seen in up to 40% of patients who have severe TBI and can impact outcomes. Nimodipine doesn't really prevent vasospasm, but it does improve outcomes in aneurysmal subarachnoid hemorrhage, but may be detrimental in people with TBI and should not be used. The mainstay of medical management is euvolemia, induced hypertension, cardiac output augmentation. Milrinone is becoming increasingly common. IA vasodilators and angioplasty can be rescue therapies in people who are refractory to medications. Intraventricular nicardipine can be considered and may reduce the need for serial IA treatments. And then medications targeting cortical spreading depolarization. Cilostazol may have a role in both traumatic vasospasm as well as vasospasm and subarachnoid hemorrhage. Thank you.
Thank you, Dr. Vishank. We'll move on to the next speaker. And next speaker is Dr. Vivek Kumar, is the chief intensivist at our hospital. Has multiple publications, is the first Indian intensivist to clear EDEC course, that is European Diploma in Advanced Intensive Care Echocardiography. He was principal investigator RFH for Placid trial. He's the program director for ISSCM ICU fellowship program for respiratory therapists. His areas of interest, excuse me. His areas of interest are ultrasound and POCUS. He has been to working with various institutes and is from RB background, and he's going to speak today on acute delirium in COVID-19 pandemic. Vivek, all yours.
Thank you, sir. I would like to thank Dr. Arun Shah and the organizing committee for giving me this opportunity to address a problem which actually peaked this year during the pandemic. Well, there can be no better beginning to it than by doing the traditional Indian namaste, and that means I bow. One of the best reviews on the topic for today came in Nature this year, where they reviewed delirium extensively and looked into all aspects of delirium. The word delirium comes from the Latin word delirar, that means to deviate, and there are certain characteristics which I have listed on the slide. It is an acute onset problem. It fluctuates. And it fluctuates both in the presence. It may be there on certain days, it may not be there on certain days, and it fluctuates in severity. In delirium, we have issues with attention, awareness, arousal. The patient can have reduced arousal or reduced responsiveness, and on the other hand, he can be hyper vigilant. Then there are issues with agitation, alteration of mood, delusion, hallucinations, and psychosis. But the most important thing is that it is distressing. It is distressing for the patients, it is distressing for the families, and it is distressing for the caregivers. If we look at the traditional risk factors for delirium, there are many. There are premorbid factors, the factors related to the presenting illness, and there are post-admission factors. But just to cut it short, so many of them are the factors which are present in patients with COVID. Advanced age, high comorbidity burden, acute infections, dehydration, electrolyte imbalance, acute kidney injury, seizures, heart failure, failure of non-invasive ventilator, ventilation longer than 96 hours, severity of illness, unplanned admissions, then pain, infection, invasive devices, immobility, metabolic derangements, blood transfusions, opioids, polypharmacy, sleep deprivation, environmental factors, day-night disorientation, lack of communication with family, deep sedation, use of invasive devices, physical restraints, poor sleep, opioids, psychoactive drugs, use of benzodiazepines, immobility, and longer duration of ventilation, infusions of benzodiazepines and opioids, and physical restraint. None of the factor is less compared to the other, and all of them hovered around the COVID patients, especially the ones who were into the intensive care unit. So I have picked up two studies which have actually looked into delirium in the critically ill COVID patients. And between the two studies, I have pieced together how this acute delirium in this COVID pandemic took place. So the first study was the prevalence and risk factors for delirium in the critically ill patients with COVID-19. And this was basically coordinated by the Vanderbilt Medical Center, which we all know, by Wesley Ellie and his group. They picked up about 2,000 plus patients, 69 ICUs, 14 countries. It was a retrospective study where enrollment stopped before 28th of April, and they studied the patients for a duration of 21 days or 28 days. They picked up critically ill COVID patients. The median SAPS score was around 40. 97% of these patients had ARDS at admission, and most of these ARDS were moderate ARDS and severe ARDS. Invasive mechanical ventilation was there in 66% of patients at admission and 87% at any time during hospitalization. 66% of these patients were prone for a period of 4 days. Benzodiazepine use was there in 64% of these patients for a median duration of 7 days. Propofol use was there in 70% of these patients for a median duration of 7 days. The median RAS score in these patients was -4. -4 means almost completely knocked out, deep sedation. Dexmed use was 44% of patients in 4 days. A lot of these patients received neuromuscular blocking agents. There was restricted visitation in most patients. Although this was a retrospective study, they picked up centers where prospectively CAM ICU scoring or the intensive care delirium screening checklist was done daily, and the ABCDEF bundle was done on most days. Restricted visitation, 99% of patients. Visits were completely restricted in 41% of patients, while visits were only in limited times during the day in 6% of patients. And in 53% of patients, visits were allowed only when the patient was dying. Staff reported facilitated virtual contact in almost 94% of the patients. It was there for full duration of stay in 94% of patients, but it was there only when dying in 6% of the patients. And if we look at the ABCDEF bundle, which I'll come to subsequently, element F, that is family engagement and empowerment, was present in only 17% of the study days. These are certain characteristics which are very obvious from the study. So the primary outcomes was basically coma. The prevalence of coma was 81%, and they defined coma by GCS less than 8 or a RAS score of -4 or -5. The median duration of coma was 10 days. Delirium. The prevalence of delirium was 55%, and the median duration of delirium was 3 days. Most patients had hyperactive delirium, which was more than 50%. Putting it together, acute brain dysfunction defined as coma or delirium was present for a median duration of 12 days, and days alive without delirium or coma in 21 days were just 5 days. So only 5 out of 21 days were the days alive without delirium or coma. Sorry. And when we look closely at this forest plot, which actually points the factors. So when we look at these factors on the left hand side, if these factors were present on day -1, that means suppose they are present today, their presence portends the development of delirium the next day. And they are all common factors which are present in most ICU patients. SAPS-2 score higher, current smoker or alcohol abuse, use of invasive mechanical ventilation, use of vasopressors, use of restraints, use of sedative infusions, especially benzodiazepines, use of continuous opioid infusions, use of antipsychotics. And all of them increased the odds ratio and was statistically significant in portending the development of delirium the next day. The only protective factor was visitation from family or friends, which had a protective effect, and it reduced the odds ratio to 0.73. So if from these factors they derived a score, and it is like this: if most of these factors were present on the today, the patient had more than 17 times the chances of developing delirium tomorrow. And similarly, if these patients factors were present today, most of these patients had almost 6 times the chances of developing coma the next day. Then they looked at factors which predicted days alive and without brain dysfunction. That means the patient is fine, the GCS is more than 8, the RAS is -3 and below. Okay, and again they found that the only factor protective was the female sex. Otherwise, all the standard factors, increased age, increased SAP score, smoking and alcohol status, use of ventilation, use of vasopressors, they reduced the presence of days alive and without brain dysfunction. Amongst the secondary outcomes which they studied for a period of 28 days were death, ICU length of stay, and ventilator free days. And what they found that 29% of these patients died within 20 days, 28 days, and most of them died in the intensive care unit. The ICU length of stay median was 14 days, while the ventilator free days out of 28 days was a median of 7 days only. So therefore, they said that based on their data, and this matches with the data from other centers, there is an increase in the incidence and duration of delirium in COVID as compared to non-COVID patients. There is also an increase in the incidence of hyperactive delirium, which was seen in more than 50% of delirium cases for a median duration of more than 2 days. This increase in delirium is correlated to the increase in COVID severity, and they found that it was the increase in COVID severity and a greater intensity of respiratory support which increased the risk for delirium. And they also noted that reduction in benzodiazepine use, it reduced the incidence of delirium. So if we have benzodiazepine use, I'm sorry for this arrow, it increases the incidence of delirium almost 59 times. And family visitation reduced the incidence of delirium next day by 27 times. Okay, so benzodiazepine use and family visitation were two factors which could be modified for reducing delirium. As far as the increase in delirium was concerned, they noted, and their explanation was that why is it related to increased COVID severity? And they perceived probably, one, is it the direct effect of COVID? But then there were question marks about it. They also felt more strongly that it is the effect of hypoxia, coagulopathy, heavy sedation and analgesia, immobility, which contributes to increased delirium incidence and severity as the COVID severity increases. They also noted that with increased respiratory support, the use of mechanical ventilation increases the incidence and delirium of COVIDs much more than patients who don't need mechanical ventilation. Another explanation they found was that during the pandemic, there was reduced practice of evidence-based medicine anti-delirium strategies. And to put it together, they have advocated what is known as the ABCDEF bundle, which is a part of the ICU liberation bundle, which has come out from the same center, wherein A, we assess, prevent, and manage pain. In B, we give spontaneous awakening and breathing trials to patients on ventilator. C is choice of analgesia and sedation, where we avoid benzodiazepines. D is assess, prevent, manage delirium, where we actively scan the ICU patients for delirium. E is early mobility and exercise, and F is family engagement and empowerment. And I think it's obvious to all that most of these things could not be brought into practice during the pandemic. This bundle has been shown to improve outcomes in the short term, and it reduces the development of post-intensive care syndrome in the long term. They also noted for increasing incidence of delirium that there was a adherence to a lot of non-evidence-based medicine COVID protocols. There were many COVID protocols which were propagated, which had a very faint evidence base. And there were things like use of neuromuscular blockers, use of deep sedation, use of prone positions, and use of high peeps. Of course, they also noted that there was an effect of the pandemic. There were increased patient surge on the ICU. There was a reduction in the ICU trained staff, and there were inadequate resources. They noted that if we use benzodiazepines, the incidence of delirium goes up 59 times. And they noted that family visitation reduced the incidence of delirium next day by 27 times. The important thing is this made a difference whether it was in person or it was virtual. And family visitation, as per literature, has been noted to reduce anxiety, length of stay. It increases the sense of security in patients, gives satisfaction to the patients, and it results in an improvement in quality of care. The point about delirium is, does it end with the ICU stay? It increases ICU mortality, and later on it predisposes and increases the incidence of dementia. It increases the incidence of what is known as the post-intensive care syndrome. Cardinal features are depression, anxiety, and post-traumatic stress disorder. And post-intensive care syndrome is not only restricted to the patient, it is of two types. P is patient and F is family. The other paper came out from France, and here they discussed delirium and encephalopathy in severe COVID-19. Well, they took only 150 patients. This was a prospective study, almost at the same duration. Median SAPS score was 49. 100% patient had ARDS. The primary outcome was incidence of delirium and abnormal neurological examination. So they had mixed up both the things together. It's delirium and or abnormal neurological examination. And the secondary outcome was the type of delirium, duration of ventilation, ICU length of stay, and mortality. So here they found so they had two subset of patients, COVIDs. One was no delirium and normal neurological examination, which was just 22. The second was delirium and or abnormal neurological examination, which was 118. There was a statistically significant difference in the duration of mechanical ventilation in patients who had delirium or abnormal neurological examination. There was also an increase in the incidence of self-extubations and requiring immediate reintubations in patients who had delirium, but this was not statistically significant. There was a significant increase in the ICU length of stay in patients who had delirium or abnormal neurological examination. And of course, there was a significant increase in the use of sufentanil and propofol, both of which are sedatives and analgesics, in patients who had delirium. The good thing in this study was that in this subset of 118 patients, they lost 19, but they could manage to do CSF in 25 patients, EEGs in 42 patients, and MRI in 28 patients. These are the MRI findings. I've just taken the image from them. Basically, they were white matter hyperintensities. So MRI was done in 28 subjects. 8 had intraparenchymal white matter abnormalities. 7 had white matter microhemorrhages. 4 had flare hyperintensities. 17 had subarachnoid spaces flare and T1 contrast enhancement. They also managed to do check the cerebral blood flows in about 26% patients, and they found that in 17 out of 26 patients had abnormal cerebral blood flow pattern, as is in this image. It is both the temporal lobes, and here in this image, it is in addition, it is in the left frontal lobe, a reduction in blood flow. They also did CSF in about 25 patients. The important thing is they documented positive SARS coronavirus RT-PCR in CSF in only one patient. And this patient actually had a negative RT-PCR otherwise. So this is one. They found elevated interleukin-6 levels in 7 patients, elevated CSF IgG levels in 9 patients, elevated CSF protein levels in 8 patients, and elevated nucleated count in 3 patients. So overall, 18 out of 25 CSFs were abnormal. And of course, they did EG in 42 patients. 26 had non-specific changes. 11 had low voltage rapid rhythms. And the 26 had non-specific changes, which were the low voltage rapid rhythms, and 11 had bifrontal slowing. Now, in their discussion, again they report there is an increase in incidence of delirium and abnormal neurological examination in COVID versus non-COVIDs. So typically in non-COVID ARDS, we have an incidence of 43 to 56%. In delirium, it goes up to almost 84%. There is an increase in incidence of hyperactive delirium, and they found it extremely high, 86%. And this delirium results in increased duration of mechanical ventilation, increased ICU length of stay, increased self-extubation, and is more in males. They have a small chat on delirium versus acute encephalopathy. Delirium, they say, is acute, fluctuating, changes in attention and cognition, while acute encephalopathy is a rapid pathological process which progresses over less than 4 weeks. In their explanation for the involvement for the delirium and or abnormal neurological findings, they have given more weightage to the inflammatory hypothesis vis-a-vis the other group. They say that CSF viral RNA was seen in one patient. CSF also showed mirror pattern oligoclonal bands. CSF showed increased proteins, IgG and IL-6 levels, and subarachnoid contrast enhancement suggested an abnormal permeability. And the last thing they noted is, despite all this, the incidence of delirium is still underestimated. So therefore, putting it all together, COVID is a difficult phase. There is fear in the community. There's profound anxiety in the patients. There is fear of isolation. There is uncertainty of disease and outcome. There are changes in attitude and behaviors of healthcare providers, and there is lack of trained manpower and resources. These are the challenges we face. But we need to adhere to evidence-based medicine practices. Evidence-based practices do less harm. We should be skeptical of embracing new practices even in new scenarios. One should practice lung protective ventilation and remember that it protects other organs also. Bad ventilation by organ crosstalk results in bad kidneys and other bad organs. Avoid deep sedation, and one should increase compliance to the ABCDEF bundle. It has been shown to reduce delirium. Non-pharmacological measures remain the foundation. Be human. These are times of distress. There should be respect for life. Facilitate sleep. Try to maintain the circadian rhythm. Ensure hearing and vision. If the patient has got specs and hearing aids, they should be provided with it. Ensure mobility. Physiotherapists help. We use physiotherapists. Ensure connectivity with family and friends. Practice reorientation strategies at least once per nursing shift. Identify anxiety and depression and actively use counseling and the help of a clinical psychologist. And in the ABCDEF bundle, we have these elements, each of which is focused to a particular thing. Assessment, prevention, and management of pain. It identifies pain and it addresses untreated pain as well as it addresses over sedation by the use of analgesics. The use of spontaneous awakening and breathing trials, it again reduces over sedation, it reduces the ventilation, reduces the duration of mechanical ventilation. Choice of sedation and analgesia, again, it checks over sedation caused by analgesics, over sedation caused by sedatives, and exposure to deleronergic drugs like benzodiazepines. Routinely and actively screening for delirium, it checks the disordered sleep-wake cycle and it picks up delirium. Early mobility and exercise checks immobility, and family engagement and empowerment reduces disorientation. So delirium risk factors, these are the ones which are targeted by this bundle. But one has to be very clear that it has to be more than a 60 to 80% compliance with elements of this bundle to deliver the results next day. So if we have compliance with all the elements of the bundle, at least a 60 to 80%, next day we can expect the duration of ventilation to go down, pain to go down, coma to go down, delirium to go down, and the use of physical restraints to go down. Pharmacological measures do not yield robust results. We had the Mind USA study this year, which was a negative trial for haloperidol, ziprasidone, and placebo. The Society of Critical Care Medicine Pain, Agitation, Delirium Guidelines of 2018 just say that haloperidol can reduce agitation. Dexmedetomidine facilitates wean if agitation is an issue. The level of evidence is low, and melatonin gives mixed results. So in my last slide, I just want to highlight that there is something known as the Humanizing ICU project, which is a concept which builds interaction between patients, families, healthcare workers. It is based on communication, and they harp on things like flexible visiting hours, patient well-being, presence and participation of family, care of the professional delivering the care, post ICU syndrome, humanize architecture, and end of life care. So this is a good concept, and we should not forget it and apply it. So this is all I have to say, and thank you very much.
Thank you. Thank you, Vivek. We come to the end of the session. And if anybody has any questions, Dr. Rahul, any comments?
It was a wonderful session, and we had a lot of good talks about various aspects of strokes as well as neurocritical care, and I hope that the second day also will be as good as day one. Thank you.
Yeah. Anybody, any questions from from audience? I know we have exceeded the time. Okay, thank you very much. Thank you, Dr. Abhisha, sir, for this wonderful session. Thank you.
Hello. I must thank Dr. Mayur Patel and Dr. Rahul for chairing this session. And I think this is the last. We have exceeded our time by about 25 minutes. I think tomorrow will be a better day, and let's hope we can continue with the same gist tomorrow also. See you tomorrow all. Thank you. Hello. There is one question. Hello. I think the somebody can answer this. Maybe Mehul or Dr. Vivek. Is role of prone ventilation for refractory hypoxemia and ARDS in patient with traumatic brain injury? Is it strict? No, or we can personalize our approach for ICP monitoring tool and that. I think it's a good question. Then would you like to take it up? Mehul?
Yeah. So for refractory hypoxia, prone ventilation is approved therapy, and with a lot of these trials proving that prone ventilation helps to improve oxygenation and cerebral perfusion. But the problems with prone ventilation and traumatic brain injury is because you're proning them, and if they've got a raised ICP, then and you've got any of these ICP devices in place, there is a risk of any of these devices getting dislodged and then having problems. So a lot of studies which were done have shown that they've used proning for a short period of time and probably 3 to 4 hours, and then tried to make the patient supine. However, all the studies, for example, the ARDS net protocol, all of them, if you see, have always excluded patients with traumatic brain injury. So this still remains to be, as I had shown in the guidelines, which was put forward by the European Society, it still is no suggestion and no recommendation as of now. So as of now, there isn't a clear-cut answer with regards to the use of ICP monitors and prone ventilation in traumatic brain injury with refractory hypoxia. Thank you.
Yeah, that's the only question. Thank you, Dr. Mehul. And I think with this, we'll end today's day. Thank you.